welcome you all for the 14th Annual Continued Medical Education Program organized by Sundaram Arulrhaj Hospitals. In the last decade, clinical medicine has witnessed a rapid stride forward. The desire and endeavor of ACME 2022 is empowering Indian doctors with creative, continuous, and significant new knowledge. And this scientific program will be a continuation of this learning process. We shall have the inauguration ceremony of ACME 2022. For this, we request our chairman, Dr. Arulrhaj sir, to come onto the dais. We request Professor Dr. K. Srinivasan sir to come onto the dais. And also we request our director, Dr. Kannan sir, also to come onto the dais.
Let's start our today's program with a prayer. I request our director, diabetologist, Dr. Aarti Kannan, to say the prayer.
Physician's prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child, I may rely on thee. SAH prayer. Almighty Lord, the source of pink health, peace of mind, and perennial happiness, we submit a heartfelt gratitude for healing the dreadful and the chronic patients through our hands. Bless our Sundaram Arulrhaj hospitals with all the doctors and staffs. Let them shine up in their efforts to heal the sick and develop the science of medicine. We thank you, O Lord, for picking us for this health services to create the healthy longevity for healthy citizen and healthy, vibrant India. Thank you.
Thank you, ma'am. Light, a source of brightness which lights up happiness, and visualize a new path which was immersed in dark. I now kindly request Dr. S. Arulrhaj, Dr. Kannan, Dr. Madhi Prakasam, Dr. Narendranath Jana, and Dr. Ganesan for lighting of the Kutuvilakku. Dr. Madhi Prakasam, Dr. Narendranath Jana, and Dr. Ganesan for lighting of the Kutuvilakku. Thank you, everyone. Thank you, everyone. We kindly request Dr. K. Srinivasan to say a few words and start this session. Inaugurate this session. Thank you, everyone.
Good morning. I think it's a very pleasant opportunity to be with you all.
Thank you, everyone. We kindly request Dr. K. Srinivasan to say a few
CME
words and
programs
start the session,
organized with the
inaugurate the session.
by Dr. Arulrhaj and his
Thank you, everyone.
very methodical team over decades. Good morning. We have had such programs for decades. I think it's a very pleasant opportunity to be with you all.
Thank you, everyone. We kindly request Dr. K. Srinivasan to say a few
CME
words and
programs
start the session,
organized with the
inaugurate the session.
by Dr. Arulrhaj and his
Thank you, everyone.
very methodical team over decades. Good morning. We have had such programs for decades. I think it's a very pleasant opportunity to be with you all.
Thank you, everyone. We kindly request Dr. K. Srinivasan to say a few
CME
words and
programs
start the session,
organized with the
inaugurate the session.
by Dr. Arulrhaj and writing about
Thank you, everyone.
very methodical team over decades. Good morning. We have had such programs for decades. I think it's a very pleasant opportunity to be with you all.
Thank you, everyone. We kindly request Dr. K. Srinivasan to say a few words and start the session,
Organized
inaugurate the session.
very by Dr. Arulrhaj and writing about
Thank you, everyone.
very methodical team will grow in over decades. Good morning. We have had such programs for decades. I think it's a very pleasant opportunity to be with you all.
Thank you, everyone. We kindly request Dr. K. Srinivasan to say a few words and start the session,
Organized
inaugurate the session.
by Dr. Arulrhaj and writing about
Thank you, everyone.
very methodical team will grow in over decades. Good morning. We have had and cheaper. Not your bank balance grow larger and larger. That was his inaugural address. And so Dr. Arulrhaj was uncomfortable, but he was silent, either unable to accept or reject it. But Dr. Sundaram was very clever. He has faced many such audiences. He came to the mic, I think you remember, and he said, the politicians should know how we struggle to get educated, borrow from banks unable to repay, build hospitals, borrow from banks unable to repay, debt loaded, but not bank loaded. And you should realize that we need some income, at least to survive and to serve people. And he said in Tamil, Kadan Battar Nenjam Bole, Engal Ullam Taviki, banks unable to repay. He also said, build hospitals, borrow from banks unable to repay. On the ground, debt loaded, but not bank loaded. And you should realize that we need some income, at least to survive and to serve people. And he said in Tamil, Kadan Battar Nenjam Bole, Engal Ullam Taviki, banks unable to repay. Also said, build hospitals, borrow from banks unable to repay. On the ground, debt loaded, but not bank loaded. And you should realize that we need some income, at least to survive and to serve people. And he said in Tamil, Kadan Battar Nenjam Bole, Engal Ullam Taviki. It's a reality. But in this competition, some corporate hospitals are able to provide the latest updates of human service. So I am sure these programs will be very useful to upcoming postgraduates in medicine. And people like Dr. Chana from Meenakshi Mission Hospital tell you how to receive the patient in distress. Hospitals are, before he enters, able to provide the latest updates of human service. So I am sure these programs at the doorstep will be very useful to upcoming postgraduates in medicine. And people like routine care or Dr. Chana from Meenakshi Mission Hospital tell you how to receive the patient in distress. Hospitals are, before he enters, able to provide the latest updates of human service. So I am sure these programs at the
Thank you
doorstep
so much, Doctor,
will
for
be
your
very
kind
useful
words of
to
wisdom and happy
upcoming
surgery
postgraduates in
for
medicine.
collecting such a wonderful memory and to give us a message. We now request our chairman, Dr. S. Arulrhaj sir, to address the crowd gathering here with a few words.
Good morning to everybody. My respects to my teacher, Professor K.S., and our colleagues who have come on the early hours. See, I always agree on issues which are raised for and against the profession. I've been in touch with our Ministry of Health and Honorable Prime Minister on the issues of the health professionals in our country over 2 decades. He has brought it out. They always see only one side. Doctor is wearing a good pant and suit, goes in a car and stays in a 5-star hotel. How much he has suffered to get into this postgraduate qualification, 14 years he has to study. No other profession need to study that much. After that, to understand the patient and start treating, it takes another 5 years. By that time, he crosses 45. His children have started growing, his responsibility is up. And running a hospital, the issue is so, difficult that Sundaram knows it. We together, MMHRC was started. He planted Totukurin only in my old hospital. He used to join me for lunch on Sundays. He'll see the patients and then we'll have lunch at my home. Electricity, somebody can check it. Hello. Electricity. Mic is interrupted. And we know the troubles. How much? No profession works 24 hours. A lot of things can be said on that. I endorse the views of Dr. Sundaram, which was said by Professor Srinivasan. Now, doctor is a student throughout his life. Throughout his life, whatever. Now, Srinivasan is 94 years. We all pray to God that he should become a centenarian. Centenarian is more which country? Even Japan. Maximum centenarians and super centenarians live in Japan. I am sure he will make it in India also. We all wish that he should be here in his 100th year and again address us. With all our prayers, sure it will happen. The theme for today's meeting is care and cure. You may wonder why this has come. We have been taught to diagnose, treat, and relieve the symptom of the patient. A relief of a symptom is not tallying with a cure. And care is not treatment. Care is different from treatment. We have been taught in medical schools, you make a diagnosis, you do this treatment, patient myocardial infarction goes home after a stenting or a CABG. And that is not a cure. It's simply he came to you for a chest pain, he had a fall in BP, he had a dysrhythmia, all settled. Symptomatically he is okay. Cure is something which involves body, mind, and disease and disability. Therefore, that care is an excellent word. Care is what you offer to the patient's mind. Mind. That is more important. That is, we have been fighting with our former MCI to introduce the concept of communication in the medical curriculum. We all didn't know how to communicate. We were not taught how to talk to the patient, how to talk to the relative. We all learned it. Our own, positives and negatives, we all learned it. Now, on 29th of September, I think in 2018, this has been introduced into the curriculum. I talked to that and introduced the curriculum at Tirunelveli Medical College, which is my alma mater. And after that, why this came is, most of the problems, the violence on the profession is because of a communication issue. The way, all successful doctors, successful institutions have, have grown this culture of communication. That is why I thought this title should be there as the theme. My relationship with Professor K.S. started, if my memory is right, 1975, sir, when you took over as the professor of neurology at Myra Medical College when I was an internal medicine PG. He used to take class. Our chief was a little difficult person, case knows. But he will take clinics for us after the 2 hours. I mean, after 2 p.m. when he has left. We all will be there with a large crowd. And then he opened the gateway for me in Europe. With him, I had the pleasure of visiting 5 countries in Europe. I think it should be in 1980, if I am right. And he introduced to me I'm a lot of neurologists and I'm a lot of elites in neurology. First time I saw video EEG being recorded and how they make a diagnosis, how do they do the WADA's test and try to confirm the focus of a lot of things. From there, it is continuing. As he said, in every CME, he is always with us. And again, I close down with warm welcome to all the participants and faculties. And our loving prayers to our chief and teacher of teachers to be with us and bless us with his knowledge on his centenary year. Thank you all very much. Thank you.
Thank you so much, Doctor.
Just an additional comment. This was years ago, decades ago, 4 decades ago. Arulrhaj used to tell me, I was traveling quite a lot abroad for all world congresses, take notes, print them and send to all colleagues who cannot attend the World Congress at my own expense. No company sponsored my trip or expenses in those days. And Arulrhaj was telling me, you are traveling too much abroad, why don't you take me once? This is before Arulrhaj became an extensive traveler in India and outside. Now, of course, as president of Commonwealth Physicians, president of IMA, president of API, so many things, he has become unreachable nowadays. But I'm talking of those days, 50 years ago, when he was coming up in life with Sundaram Hospital. So I took him to Oxford. I was invited to give a lecture at Oxford, University of Oxford. Probably I'm the only Indian who has been given a lunch at the university lunch at Oxford. It's on the same table where Benazir Bhutto, Prime Minister Nehru, Indira Gandhi, all have had lunch. And they said they are proud to have an Indian, another Indian on the lunch table in Oxford. Oxford University people are jealous. I mean, London people are jealous of Oxford. Scotland is jealous of London. This hierarchy difference is there all over the world. So they were jealous. I was invited, whereas a London professor is not invited to give a lecture in Oxford. Arulrhaj is sitting next to me in the Oxford lecture. And Oxford professors of medicine who write textbook of medicine, they were taking notes from my lecture. So I was thinking they are going to bombard me with so many mistakes I have committed. But at the end of it, he may recall, they embraced me and said, you are a fantastic speaker, wonderful diction. You must have been born in UK or United States, educated in UK or USA, all sorts of things, because they found many clinical conditions which we have seen, but they have only read about it. That's the value of gold mine medical colleges we have in India. But we have to have a teacher to tell you what to look for in the patient and how to make a diagnosis. No internet, no online teaching will help you. This, we had the luxury in those days. With Corona spreading and again being at the doorstep, I think we are losing that patient-doctor personal in touch. We should not miss that. No amount of internet can tell you. And I think Arulrhaj, you'll remember that it was an excellent appreciation of the clinical medicine we have in India. But somebody should tell us what to look for. But you must be available in the afternoon to look for that. No, not in the crowded OP in the morning, getting tired and disappear and work in another hospital to improve your bank balance. That's the state of affairs now. But anyway, I think the Meenakshi Mission people will agree. We have too much crowd, too many clinical person. We can teach others, but we must know what to look for. That's how we go abroad to that's exactly I told the British people. I was born in India, educated in India. I came here to learn how to learn. We don't know how to learn. This is what we reach the British people or Americans teach us. I think you'll agree, material is ours. teaching may be Western, but the patients are ours. Arulrhaj has arranged so many programs here in the rural atmosphere, which has really opened our eyes that we must learn from our material and teach the rest. Thank you.
Thank you so much, Doctor.
Professor K.S. having gone into Oxford, I had the experience of being with him at Oxford University. The Vice Chancellor of the university took us in the evening to his home for a dinner. You know how he came? He was driving the car. He took us to his home. He got down, opened the gate, and then he has to open his door. I mean, home door, and then he took us, gave us some food before going to the dinner. I mean, so-called, it's a very auspicious official dinner, which is so big, so great. You see the position of our vice chancellors. They live in 10 acres of land. They have at least 50 chaps to serve them. That's the way, has. And we had the occasion to meet Professor Newsom Davis, who was his classmate, who is the editor of Davidson's textbook of, medicine, first man. And the vice chancellor was Hawkesbury, who is the author of, Oxford textbook of medicine. All these people we were able to, talk. And Professor K.S. gave the lecture there. And those chaps were totally surprised on the, CNS infection, how these things can be there. And they started putting some questions, and he was totally, walking through, and they started giving him big applause. And they wanted to ask something about tetanus. He said, this boy knows about tetanus more. And because those days in my small hospital, we used to treat a lot of tetanus. I used to paralyze the fellows and put them on, ventilator, or I used to give intrathecal, anti-tetanus serum, and I shared the knowledge. And they were so much, surprised in India, these things are happening, that in smaller centers. He is flashlight, Professor K.S., for knowledge and exposing to the youth. That's what I had the pleasure with him. Thank you. Thank you so much.
Thank you so much, Doctor. You both have been an encyclopedia of experience and knowledge, which we can keep listening for so much time. So we'll be starting the session, but before that, we have our welcome address by Dr. Archana Ambujam. We'll have this as a virtual video. She's unable to
That's
be
what
here
I had
with
the
us for
pleasure
some current,
with him.
Urgent.
Thank you. Thank you so much.
Thank you so much, Doctor. You both have been an encyclopedia of experience and knowledge, which we can keep listening for so much time. So we'll be starting the session, but before that, we have our welcome address by Dr. Archana Ambujam. We'll have this as a virtual video. She's unable to
That's
be
what
here
I had
with
the
us for
pleasure
some current,
with him.
urgent.
Thank you. Thank you so much.
Thank you so much, Doctor. You both have been an encyclopedia of experience and knowledge, which we can keep listening for so much time. So we'll be starting the session, but before that, we have our welcome address by Dr. Archana Ambujam. We'll have this as a virtual video.
I warmly welcome one and all to our academic program on this. Good morning to all. Good morning to all. It is my honor and privilege to invite you all to ACME 2022. I warmly welcome one and all to our academic program on this beautiful Sunday morning. I take great pride in saying that this is our 13th ACME program. We have been successfully conducting this program annually, and even during the COVID pandemic, We had organized it as an online webinar, and this year, with the COVID scenario improving, we have made it as an hybrid meet. ACME is the scientific dream program of my father, Dr. Arulrhaj. He is known for keeping himself academically updated and is also a dedicated teacher who is keen on spreading the latest updates in the field of medicine to the practicing clinicians of the small but smart city of Tuticorin and the surrounding districts. In today's program, we have pioneers from various fields of medicine who will be sharing with us their rich clinical experiences. I warmly welcome our guest speakers, Professor Srinivasan, Dr. Narendranath Jena, Dr. Bennett, Dr. Kumaravel, and Dr. Srinivasan Ramachandran to today's program. ACME 2022 seeks to review the existing pattern of clinical practice and discusses a comprehensive set of changes for the future healthy practice. I sincerely request you all to make the best use of ACME 2022 to enhance your knowledge and empower yourselves to the professional challenges we meet in our day-to-day practice. Thank you.
The chairpersons of this session are Dr. Ganesan, neurologist, Tirunelveli, and Dr. Kannan, neurologist from Tuticorin. We request you, sirs, to please occupy the seats at the chairperson and to introduce the speaker.
Hello? Yeah. I think we have a very heavy crowded program. So I can go long and long because of large experience, but I'll stop when you cannot tolerate anymore. So indicate it by some method. Now, next slide. Next slide. Next. I have to skip many. Now, this was the World Congress of Neurology held in London in 2020. Many Indians attended. And the first slide shown to us was this. Don't think we have become veterinarian doctors. This is called feline neurology. Feline neurology is learning about cats. Cats have got a very good ophthalmology for us to look at. Our patients have narrow eyeballs and we have a very poor torchlight. So sometimes we don't do good ophthalmology. Cats are good educators. You can see the audience was given a chance to answer this. Look at the cat and make a diagnosis. One pupil is dilated. You are asking conditions. Carefully look, one of the lower eyelids is up, the other is not. Have good vision, abnormal pupils. Good vision, abnormal pupils, and absent ankle jerks. In addition to this, next slide. The answer is Horner syndrome. And there are so many neurological diagnoses you can make if you first diagnose Horner syndrome. If you miss it, you miss the diagnosis also, in spite of costlier gadget-oriented investigations. As you can see, this can occur. Absent ankle jerk and Horner syndrome features can occur in Arulrhaj people due to syphilis. I must share with you, Madurai has the largest neurosyphilis fully recorded, 4% of primary syphilis. Those who have primary chancre, 4% of them develop neurosyphilis, largest in world, largest, fully proved by WHO-sponsored VDRL, WHO-sponsored immunological investigations. We send our sample to Chennai, they send it to Switzerland. They send their samples of Switzerland to Chennai. Some of them are sent to Madurai. So our hospital is recognized as 90% reliable. More 90% of the private laboratories gave wrong or false positive or negative VDRL and other tests in syphilis. So I think this is published world over. But why, with 4% of syphilis in Madurai, I became a mocking the man in many world congresses, saying Dr. K.S. is from a polluted, highly sexy area called Temple City, but the practice is something else. So I said that's not the reason. Madurai, on the road, 90% are not Madurai citizens. Like London, when you walk on the street of London, most of them will be foreigners. If you ask them where is Charles Street, he'll take you to the side, look at the road map and tell you where it is. You would have already had the map in your pocket. Feel foolish if you ask somebody else to look at the map. Likewise in Madurai, most of them are visitors, tourists from the north. So I said, we imported the tourists and exported something which you gave us. So Madurai has very rich in neurosyphilis because we are polluted by too many visitors because of it's the temple city. That's the reason. So we have a very high incidence of neurosyphilis. That's because we looked for it. We did the lumbar puncture in all people, 200 of them who had primary syphilis without neurosyphilis. Then the lumbar puncture in people who have neurosyphilis confirmed the diagnosis by all tests. Now, next slide. Just looking at the pupil, sometimes you can make a diagnosis. You can see here patient with dimness of vision in one eye. And you find here pupils are normal. Show the torchlight to the right eye. Both of them constrict. Show the torchlight to the left eye. Nothing happens. So, you know, there is something wrong with the left pupil. And you find that direct consensual is okay, but direct is absent. Vision is poor here. The only diagnosis is optic neuritis. So with a good torchlight, with a live battery, which is sometimes absent, sometimes you use torchlight to find out another torchlight, which is good enough. That should not be a torchlight. Next slide. Next slide. Next slide. Now, this is a very important slide of a normal pressure hydrocephalus of a very rich Sivagasi businessman who had millions of rupees in the bank and too many friends to spoil him doing doctor shopping extensively in India, in the United States and UK. He came with incontinence of urine, depression added to his problems, misery, somewhat responding to antidepressants, headache, incontinence and ataxia and so on. And this was the MRI showing very large ventricles and radioactive serum albumin injected into the CSF showed that it doesn't get out of the to the sagittal sinus in 24 hours, saying he has a block in the sagittal sinus due to some previous head injury. His brain was normal, but his brain was declining. He did not get operated as a dress, went to CMC Vellore, went to Professor BRM in Chennai, went to Mayo Clinic. Every 6 months, he will travel to have 100% cure assured. Every time he went to the next center, they said, you will improve 60, 70%, 50%, 40%. But he wanted 100% improvement in somewhere in the world because he could afford. And he died without any surgery. He could have been completely cured with surgery on the first attempt in Madurai itself. He missed it. Next slide. Sometimes a good die. Next slide. Now, this patient was from Tuticorin, a doctor practicing Tuticorin, who was found misbehaving such as colleagues and also writing inappropriate prescriptions, corrected by the nurse and improved by the pharmacist before dispensing. It went on for some time until he became ataxic, tremulous handwriting. And all that we should do is for neuropsychology. You can see he could not draw the map of India through Bombay into the sea, along with the terrorists, Dawood Ibrahim also included. And he couldn't place where Chennai was, so on. He couldn't draw a star, and he couldn't connect the numbers. These are very specific right brain dysfunction. He was a rare alcoholic, but a regular alcoholic. And you can see when he draws, there's a gross neglect of spatial neglect. Now, you don't need a costly investigation for this. Just a paper and a pencil, I could make a diagnosis. He has got portal systemic encephalopathy, which affects specifically right brain. And an electroencephalogram, there's a normal EEG, and you get mid-positive triphasic complexes all over the right brain, not much in the left brain. This is 100% clinically diagnosed portal systemic encephalopathy. And we did this splenogram and spinal portal venogram and referred him to the gastroenterologist for further action. So I just tell you that clinical neurology can be more effective, cheaper, as long as you use your brain and not the gadgets too much. Next slide. I think you know all about this. I will not bother you. Next slide. And you blame alcohol. I just want to share one thing here. In the United States, they have reduced the mortality due to ischemic heart disease, but not the mortality due to cardiovascular deaths. It's still high. And 35% of cardiovascular deaths are sudden deaths occurring outside the hospital. So we still have a very high mortality of cardiovascular death, although ischemic heart disease mortality has come down in US particularly because there are better statistics. And you find in Russia, some time ago, I'm sure you have better statistics, the commonest cause of death was alcohol. Postmortem rooms in Russia are full of alcohol deaths. Some of them have central pontic myeloclonus, not all of them. Alcoholic dementia, peripheral neuropathy, all are very common. And it's a reversible dementia, alcoholic. If you stop alcohol, you get a normal brain, even in MRI. Now, I don't know what is the problem now. It's with vodka, you have to die. It's like dying with a beer. You have to drink a lot, not like whiskey. So I'm sure, very good. I don't know now what's the position in Russia, but they have, alcohol is still, the place to study about alcohol is Russia. You can go to Russia and study. And it produces not only cognitive failure, portal systemic encephalopathy, and a reversible, curable condition called Wernicke-Korsakoff syndrome with vitamin B1 and glucose. If only you make a diagnosis, not miss the diagnosis early. Please read the following lines. All said and done, we wait for the evening, because at the end of the day, take-home message is classmates are sometimes more helpful than classmates. Next slide. Now, even the tumor affecting the right brain, the same diagram can help you. You will find that some of them are spared. See, this lady with a very large right brain tumor has a very good drawing on both hands. And she misses the letters on one side, A, showing spatial intention. And she draws a cycle You can see this is a left brain damage cycle. The cycle looks beautiful, but it cannot run. The right brain circle will be poorly drawn, but it can run still like an old man. So I think a simple test can tell you, even in brain tumors, that if she has a hemianopia, the medial side of optic visual line will be absolutely straight in a vascular accident, whereas in a tumor it will be irregular. And there are many simple bedside tests to tell you you're right or wrong. You need not have gadgets to diagnose a tumor from alcoholic portal system. Next one. And this is a beauty of neurology. You should listen to older teachers for this. Younger teachers may not know this. I hope you know what it means. Polio encephalitica hemorrhagica superioris. Polio means anterior horn cell or gray matter disease. It is nuclear disease in the brain, anterior horn cell in the spinal cord. Encephalitis means it's in the brain, not in the spinal cord. So it's a nuclear disease in the spinal cord, not white matter disease, not a demyelination. Hemorrhagica, there is a hemorrhage without aneurysm or without other causes of hemorrhage. Superioris, superior inferior in neurology means superior is pons, superior is midbrain. We don't mean brain hemispheres except for cognitive function. So we know where the disease is. It's a midbrain, hemorrhagic, gray matter disease, and you know what it is. Next one. These are only older textbooks, not in modern textbooks. Next slide. This is a lady in Madurai who is a social worker wandering in the streets of Chennai, picked up by a neurologist who did a brain scan, found a small bleeding near the basal ganglia, diagnosis an early stroke, treated with thrombolytics and so on. She didn't improve, she became worse. She rushed back to Madurai, to her hometown, and we found she had a lot of cognitive neurology, and she was confused, disoriented, trying to explain the situation, very poor recent memory, all bedside neurology, not gadget oriented. Next slide. Next slide. Active social worker, inadequate control of afebrile normotensive. She gradually improved with control of diabetes, vitamin IV, B1 IV, and later orally. Now you know the diagnosis is B1 responsive neurology called Wernicke-Korsakoff syndrome. Next slide. Misdiagnosed as stroke because of bleeding in the midbrain. She had all this. Let's not go into full neurology, but it shows he has ophthalmoplegia, ataxia, behavior disorder, but no motor signs. Next one. And this is the fundus examination, some of them with severe hemorrhagic lesions in the retinal vascular. All of them are completely reversible by intravenous B1 with glucose. And you see the brain showing hemorrhage in the midbrain, in the stop, and lower down. Sorry, it's not working. Can you sleep places? If you miss the diagnosis, clinically, you can see the brain, the same brain in the bottle, with the postmortem confirming medial thalamic hemorrhages. ಇಲ್ಲ ಇರ್ತದೆ ಇರ್ದ ಕೊಡು ಅಂತ ಹ್ಯಾಂಡಲ್ ಮಾಡ್ತಾರಲ್ಲಮ್ಮ ಇಟ್ ವರ್ಕ್ಸ್ ಓನ್ಲಿ ಫಾರ್ ಯು. Thank you. I will finish the talk before it stops working. Okay, so next one. Next one. Now, this is a lady in Tanjavur who had a problem of convincing and satisfying her mother-in-law, the recent history of marriage, because every time this was 1965. Every time she used the right arm for grinding some flour for idli, she used was well, but changes out left arm, he fainted and buckled. This irritated the mother-in-law. She thought she was pretending with some punishment. So at Tanjavur Medical College Hospital, in the outpatient, I found she had a left radial pulse was weaker than right side. Blood pressure was low. There's a bruising at the supraclavicular region. So what she had was subclavian steal syndrome, not yet described in world literature at all, even in neurology textbooks, 1965. But it was described in a journal, social journal, in those days, American Times, British Times, etc., well studied. And the angiogram shows proximal to the vertebral artery, there is a subclavian stenosis. It can occur in Takayashu, it can occur in Athiroma. So the mother-in-law has to be explained, told some good neurology to accept her daughter-in-law as not pretending, but really sick. And she should be spared of grinding some idli mav. Next one. Carrot, Takayashu we see plenty in Madurai. I will not go into it, but you must know, feel the pulse and BP in all the limbs. Not do a online neurology or a corona protected neurology, not going near the patient and making a diagnosis at distance and collecting your fees. Corona neurology will miss all this. Next one. And same picture. She refused shunt. She was given only aspirin. She survived for 20 years. Other people with similar story were given stents and they're also doing better. Sometimes aspirin and natural God given Samyar blessed neurology also helps. Next one. Now, this is very important. I think I'll stop with this. They've got too many. One more and let's stop. Now, when you have a small muscle wasting, there are many conditions. If you have a sensory loss, you may think of syringomyelia or peripheral neuropathy. If you have a brisk reflex, it's leprosy. Sensory loss, peripheral neuropathy, brisk reflex. Leprosy is the first diagnosis. Diagnosed, confirmed, propagated, discovered in India. Must be proud of our country by sanatoria. And peripheral neuropathy, you must lose your reflexes with motor and sensory loss. The only condition you get brisk reflex is leprosy. We'll discuss why it is so. Now, if you have no sensory loss and you have wasting of all muscles, it cannot be syringomyelia, it cannot be leprosy, but it could be motor neuron disease. So here is a man who had wasting of small muscles of hand in London, who had gone to several neurologists, and they thought it must be motor neuron disease, but electrophysiology was negative. So they then explored the neck with investigations, not surgically, and found no cervical cord lesion. But what they missed was, this case, abductor pollicis brevis is wasted. You can see abductor pollicis brevis on the thumb is wasted. This is the first muscle to waste in motor neuron disease. Sorry, I am not abductor pollicis brevis. It's always wasted in motor neuron disease. And the last muscle to waste in motor neuron disease is triceps. No young neurologist will teach you this because this is only in older books, and older neurologists will teach you. By the time you get this type, electrophysiology is not necessary for this. So this man had a good abductor pollicis brevis, wasting of all other muscles in the hand, no sensory loss. So they thought it may be an atypical motor neuron disease. And then a senior professor helped me to diagnose it. And we learned many things from our senior professors. Thank you. That's abductor pollicis brevis. He had a good triceps, but he had also weak this one. And he found that by pressing on the thumb here, there is a tenderness, and he is diagnosed as ulnar nerve neuroma. Deep branch of ulnar nerve has no sensory innervation. D branch of ulnar nerve has no sensory innervation, only motor. So it looked like motor neuron disease. And he had it on both hands. He was driving a motorcycle as a courier driver in London and had a spiked hand grip and a powerful motorcycle. London motorcycles are beautiful, making more noise than Indian motorcycles. And you will find he enjoyed the profession and developed an ulnar neuroma by using a spiked hand grip, threatening people not to horn but drive out of by noise. The neuroma was removed and he was cured of the disease completely. I was there, missed by top neurologists in UK, in all centers, by wrong investigations. This man had only a clinical investigation. He just palpated the thumb and made a diagnosis. Good neurology can give you the best diagnosis in spite of the best of equipments. Next slide. And plain X-rays are very useful. This is the craniostenosis, tuberous sclerosis, normal spine X-ray. I'll show you. And this is plain X-ray showing neurofibroma here. Erosions of pedicles due to mediastinal tumor and spinal deposits. I think simple neurology and plain X-rays are still very good. Next one. Next one. Next, please. Next. 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 This is the last case. A young man from aged 40 from Munnar, hotel server, fair, well-built, tall, handsome chap, quarreled with some colleagues while serving the customers one day, had some gently knock on his shoulders, a little more powerful than unusual. He developed some pain and a fever in 2 days, unrelated to the knock. And then he could not breathe at all. In the lying position, he had what you may call orthopnea or nocturnal dyspnea. He could sleep in the sitting position, but he could not sleep in the lying position, supine position. So you'll collapse on a chair, sleep for the night, again work very well during the day with normal activities as a hotel server. He consulted his family doctor for his dyspnea. Not a smoker, not an alcoholic, no bad habits. Family doctor said, go to Cochin Amrudamai Institute and meet the cardiologist because you got a nocturnal dyspnea. So he went and, no, he didn't say cardiologist, meet the specialist, super specialist. He met the super specialist. They did the coronary angiogram, stress test, and found he was absolutely free in cardiology. They said it may be microangiopathy. They need a special angiogram for that, which may cost a lot. So he disappeared. Then the doctor, family doctor said, why the hell did you go to cardiologist? Your problem is breathing difficulty. Why don't you go to the pulmonologist? So he went to the pulmonologist in the same institution. Well equipped, highly brilliant people. And the pulmonologist did spirometry, arterial oxygen saturation, gas studies, everything, and found nothing wrong with him. They said you must go to psychiatry or a sleep study. Both of them was expensive. So he returned to family doctor and said, I have nothing. Tell me one investigation which they have not done. I will do that. He said, sir, I have done X-ray chest, but nobody looks at the X-ray chest because they are looking at angiograms, spirometry, all costly things, gas values. But somehow X-ray is not attracting to super specialists. The doctor looked at the X-ray again, said there is something wrong. You better go to Dr. K.S. in Madurai. He is good in small things, may not be good in big things. I looked at the chest X-ray and you can see the diagnosis of chest X-ray. He said bilateral diaphragmatic palsy, missed by super specialists in super institutions because somebody said cauliflower is nothing but cabbage after college education. Mark Twain, a brilliant man. He said he never smokes when he sleeps. He never stays off a cigarette when he's awake. It is Mark Twain. He lived long. Did not die of pulmonary cancer. Because to die of cancer, you should smoke at least 10 cigarettes a day for 10 years continuously. Then only you'll get lung cancer. But to get coronary heart disease, thromboangiitis obliterans, stroke, even 2 cigarettes will do. So you must not smoke, but teach them properly. Now, this man, this is a normal chest X-ray. With after deep inspiration, it goes up to even 6 to 8 centimeters down with a very large breathing space, ventilatory space available by diaphragm. Whereas this is a patient with bilateral diaphragmatic palsy with both the diaphragmatic higher up. This is normal, this is abnormal. What I did was a phrenic nerve conduction in Apollo, confirmed the delay both in latency and amplitude, gave him some steroids, some antibiotics. He's totally normal, followed up for 10 years later. He came to me previously. He's absolutely normal, but one diaphragm is still very weak. Now, diaphragmatic palsy is often missed by pulmonologists and anesthetists. No anesthetist assesses the diaphragmatic function. All of us assess only intercostal function. Diaphragmatic function is assessed rarely. In Oxford, most pediatric surgeries are done with a esophageal transducer, which is monitoring the diaphragm throughout, along with the blood gas values. Blood gas values tell you the result, that you have passed or failed. It doesn't tell you in which subject you have failed. So therefore, some of them cannot be weaned out of ventilation. Anesthetist has to be pumping oxygen for the whole day for one surgery because diaphragm has not recovered. In ICUs, diaphragmatic palsy is totally missed and gets damaged by myolysis on the 4th day of a mechanical ventilation. There are people in the ICU for months together, you know that. 4th day, they have done diaphragmatic biopsy. So some of the poor recoveries and the post-COVID syndromes, maybe due to diaphragmatic palsy, not resume their occupation, although they are cured of COVID and with having spent lakhs of rupees. I think this is a small point. We don't assess the diaphragm. How is the diaphragm assessed? All of us as medical students know some test for diaphragm, which is called, you take a deep breath, percuss the upper border of the liver, its lower border of the 5th rib. Ask him to take a deep breath, liver goes down, and that area becomes resonant now. It's called tidal percussion. This shows the diaphragm is working. You can use your fluoroscopy to confirm what I said is right or wrong. Diaphragm acts on the epigastric angle. Take a deep breath, epigastric angle widens. Take a deep, breathe out extremely, epigastric angle narrows. It's called Litton's sign. From that you can know whether the diaphragm is paralyzed or not. But if it's paralyzed at T10, much lower, beware sign, umbilicus moving up helps you, but it's too late. So I think there are some clinical signs for a diaphragm. Now, why is diaphragm important? It's the only muscle because of which we are all alive today, having had a good sleep yesterday. In the night, what keeps us alive is the diaphragm. It's a very powerful ventilatory muscle, but not clinically assessed. In American Anesthetics Association, they do what is called sniff test. That's the only test as the diaphragm. Not coughing, not sneezing, not yawning. Hiccough is diaphragmatic function. Hiccough, but that is not an induced hiccough. So therefore, we miss diaphragmatic palsy easily. Cardiac surgery, thoracotomy, they damage the left phrenic nerve very often, but neither the anesthetist is aware nor the patient is aware because they are asymptomatic. You need only one diaphragm to survive without any symptoms. It will be diagnosed only if you take appropriate. So cardiologists also miss in thoracotomy. It can be injured in 20% of cases of thoracotomy easily. And it recovers later on, it may not recover, but you are asymptomatic. It's involved in infective polyneuritis, in leprosy, in tetanus, in many conditions. And we have a belly Down syndrome and diaphragmatic flutter, hysterical as well as dyskinetic syndromes available to neurologists to spend their time if it's not spent otherwise. Now, we have therefore diaphragmatic diseases plenty, but we ignore them. But for surviving in the night, we need diaphragm. I'll tell you the story. Next one. Next one.
Respected sir, it's 30 minutes.
Over.
Yeah, yes, sir. Can take a few.
Last slide.
Yes, sir.
Now, on the slide, sorry, you can see the amount of ventilation we get by diaphragmatic inspiration. It's a very important muscle, but we don't test it at all. And this is how we did the phrenic nerve conduction and diagnosis. Next one. Next one. Next one. Now look at this lady, handsome lady, partly dressed, partly undressed, with a fish-like lower limbs. It's called the mermaid or the sea maid. Now, this is, the story is that it's called Ondain's curse. The Greek mythology with several versions, like our Ramayana also, we have several versions of Ondain's curse, Greek mythology, which says that this girl, pretty girl, was in love with somebody, sea wayfarer, for months together at a courtship, and he deserted her. So she was upset. She complained to God, Greek God, that he should be punished for deserting her, having courted for a long time. So the God said, you will die if you sleep. That's the punishment. You will die if you sleep. The meaning is, if you sleep, he paralyzes diaphragm. If your diaphragm is paralyzed, you will die on your sleep. Unless intercourse is overact by some other method. That's the message. So sometimes you should read Ramayana, Mahabharata also to learn some neurology. Now, that's the meaning of this picture. Please, next slide, last slide. This is tell you that many years ago, this is a picture taken 20 years ago, we inert carotid Doppler, ultrasonography, sonothrombolysis by physical, emotional, cultural, and anatomical methods. Now you have got better equipment. Thank you.
Thank you, sir. We request the chairpersons, Dr. Ganesan, sir, to initiate the session, sir.
I don't think I can make any comment on my guru's talk, but I would like to say something else. At the outset, I may thank Dr. Arulrhaj and his team to give me this opportunity to chair this session, a session that is extraordinarily, because it is quite unfair for me to sit on this chair when my guru is talking there. What I initially thought was I must sit there and listen to him. But the reverse has happened. Anyway, once again, I thank you, Dr. Arulrhaj and his team. His team means his children. They are my children also. When I say Dr. Arulrhaj, I always used to say, a rare combination of human genius, perseverance, and compassion. For him, I am indebted a lot, because my neurology career started in Tuticorin. After I completed my DM under my guru, my first posting was here in government hospital. And we had a very, my starting career was something very excitable because I still remember the day when I did my first myelogram. At that time, there was no MRI here. You have to go to, I think, Chennai or Hyderabad for the first MRI. I did my first myelogram at Dr. Madhipravasam's hospital. I hope you remember, sir, to find out a meningioma of the spinal cord, and invited Dr. Suresh Babu, a neurosurgeon, to come over here to operate on that. So these are all some unforgettable memories. And the first case of multiple sclerosis I saw at Dr. Arulrhaj Hospital. A young lady, believe it or not, some 35 lesions in the brain. At that time, my student, of course, professor, my guru student also, Vijayan was there to do a plasmapheresis. In spite of beta interferon, everything, she ultimately died. And I am indebted to all the physicians of Tuticorin, including Dr. Lakshman of AVM Hospital, Dr. Danish Kodi, and Dr. Selvaraj, who are all, what do you say, encouraged me for inviting me to see their cases for a second opinion. I vividly remember a patient. Dr. Lakshman asked me to see a patient who underwent a cesarean section under spinal anesthesia. After that, she had a persistent headache, nuchal pain. So usually after LP, possibly a low pressure headache, which will usually subside on lying down, but immediately reappear on sitting position. That is the simplest way to diagnose a low pressure headache. But this was not like that. So I thought whether it could be meningitis but there were no signs of meningitis and all. We did a X-ray spine and everything. Well, I suggested a CT scan, but CT scan was not available at that time either in Tuticorin or Tirunelveli. First time it came down to my dearest friend by Dr. Arulrhaj. Finally, they went to Madurai and CT scan. To my surprise, it was a huge meningioma of the cerebellum was jetting down in the foramen magnum. Just imagine how the anesthetist was lucky enough to, if he has drawn out a few more cc's of CCF, the patient would have died on the table. So why I am telling this is just a few memories. How my friends in Tuticorin encouraged me to become a neurologist to some caliber. And Dr. Arulrhaj used to conduct a monthly clinical meeting. And that was particularly on Wednesday, mainly for my sake, because Wednesday was a free day for me. And those are all really memorable days. And usually it was customary for the chairperson to talk a few words before the speaker starts his talk. Because I thought when my guru was speaking from the dais, the chairperson must talk a few words. What I felt was when the guru was talking on there, it is not fair on my part to sit on this chair. Yes. Yeah. Yes. Because why I say a guru is, I don't call a teacher because there is a lot of difference between the word guru and teacher. You know, the word guru means a Sanskrit word. In no other language, there's an equivalent word in the whole world. In Sanskrit, gu means darkness. Ru means a man who dispels the darkness from the mind of a person. I hope you understand the meaning of that. Therefore, I call a guru, not a teacher. Right? Albert Einstein once said, a better than a 90 days of diligent studies of books to spend one day with a great teacher. And today is a day that I spend my day with my, I won't say teacher, the guru. Because I have already explained the meaning of the word guru. Okay? Anyway, thank you very much. Thank you very much for giving me this opportunity.
Thank you, sir, for your excellent your memories with sir. Any questions for sir? Actually, we have a session. You can have a discussion with sir at 6 o'clock at DSF. We are having a small session. You can ask all your doubts. Sir will be ready to answer all your questions also. We'd like to honor chairpersons and the speakers. Dr. Ganesan sir to hand over the memento to Dr. K. Srinivasan sir, please, his guru.
Yeah. We now request Dr. Srinivasan sir to hand over the memento to Dr. Ganesan sir and to Dr. Kannan, please. Thank you, sirs. We now move on to our next session. I kindly request chairpersons, Dr. Selvaraj, Senior Physician and Diabetologist, Tuticorin, Dr. Rajan, formerly Professor of Medicine, Tuticorin, to the chair for the session and to introduce the speakers.
At the outset, I am extremely thankful to Dr. Arulrhaj and his team for giving me the opportunity to chair this session on toxicology, along with Professor Rajan, who is my best friend and secretary serving with me in the API. And today's speaker is Dr. Narendra Jana, who needs no introduction to this audience. He has already gave talk in this auditorium. He has already gave talk in our API at DSF Plaza and APICAN at National Conference also. And he is the president of Indian Society of Toxicology and founder president Indian College of Emergency Medicine. He is an expert committee member, Poison Management, National Health Mission, Tamil Nadu. Awarded Academic Entrepreneurship Excellence Award from Indian Medical Association Headquarters, New Delhi on 2021. Editor Clinical Toxicology book and published more than 150 articles in national international journals. Awarded for excellence in emergency trauma and critical care 2021 by the Confederation of Indian Industry. And Dr. Jana has conducted so many toxicology and emergency medicine conferences in our APA forum. People who have attended his meeting would not have forgotten his slide on an accident when a boy is on the road along with the emergency ambulance carrying with him. With this introduction, I ask Jana to go ahead.
Good morning. Good morning, everyone. The most difficult part for a speaker in a CME to give lecture after a professor. It's the most difficult. And now you imagine my situation. I am giving my second talk after a legend. I think last 15 years I am in Madurai. And a couple of personality always in my mind. Of course, the first is Professor Arulrhaj sir, who is my mentor. And of course, the legend here sitting here in neurologist. Because when I was in Delhi for many times, I heard about these two personalities. So I am so privileged and honored to give my talk with his blessing to this podium. And I would like to thank Professor Arulrhaj sir, my mentor, for giving me again this opportunity to come here to speak in this auditorium, in this 14th annual CME. Also, I would like to thank Dr. Aarti madam for inviting and calling and always so kind to, for the hospitality. Tutukudi, as sir told, I should thank our chairperson so for the introduction. Tutukudi is not, as sir told, yes. So wonderful memories in Tutukudi, as sir told. And I had the opportunity to give some lectures here. And thanks again for the invitation. So, as I said, I will talk about something not different. Probably I will talk about what we are doing every day in the hospital. But the problem is here, in poisoning or toxicology, it is a medicine. It is just medicine inside a medicine. And so that most of the time we neglected to this specialty. You will be agree with me. Because this specialty is not in the hardcore in medicine. It is with the forensic medicine. And of course, after MBBS, when we started treating toxicology or poisoning patients, and most of the physicians, we have very limited experience on this. To name it, thousands of poisoning care, including snake bite or anything plant poisoning, it is really challenging, most challenging. So if you see in India, this is a public health concern. This is a public health problem because according to the WHO, every 100,000 patients, the mortality, the 2 patients, they die. So it is a huge problem. There is no straightforward guidelines. All over India it exists. Even you take it ASP, anti-snake venom. When in North India starts some institution, so 10 to 12 vials, or in South India, some 20 vials, there is a mismatch. And because there is no straightforward guidelines, the patient, not only they suffer, even the physicians, those who treat, they also suffer. So what we supposed to do? Of course, not only hold the world, the most important problem in India where we stand, and majority of this toxicology poisoning happen and to the rural village people, and they just come to the hospitals, and we have to have a streamline for this poisoning care. So what I'm going to talk about, I will give an overview how we will treat these poisoning patients, what about the antidotes, and what we supposed to follow when a poisoning patient comes to us. Oh yeah, there are some questions, MCQs for for the postgraduates here, and who will give the right answer? Dr. Aarti has sponsored the chocolate for them. So this is the first question. Indication for intubation in poison patient except obstructive airway, laryngeal edema, bronchoria, GCS more than 9, depressed sensorium. GCS? Okay, please give a clap. What's your name? Yeah, that's good. That's good. Yeah. So she will get a chocolate from Dr. Aarti. Please give. You can. So next question. The drug which doesn't cause bradycardia. Clonidine, ethanol, digoxin, beta agonist. The answer is beta agonist. Yes, you can take again chocolate. So which is not a coma cocktail? Probably most of the senior people here, we have learned, please give. We have learned coma cocktail when we saw a poison comatose patients. But now, of course, with the bedside investigations, we are not doing, but which is not a coma cocktail? Dextrose, thiamine, insulin, naloxone. Insulin, fantastic. Fourth question, contraindication for gastric lavage. Most of the poisoning patient when we receive to the emergency or ICU, we start giving gastric lavage. But which is contraindication? Conscious patient, within 4 hours of presentation, unconscious patient, none of these above. None of these above. Okay, the answer is no one. Contraindication for gastric lavage. Sorry? None of these above. Okay, no. This is unconscious patient. Okay, we will talk about why it's so. Next question. Activated charcoal doesn't absorb anything except corrosive, heavy metals, alcohol, cyanide, OPC poisoning. OPC poisoning. Antidote for iron poisoning. Fantastic. This is easiest, most easiest. Adverse effect of activated charcoal include all except constipation, impaction, intestinal impaction, charcoal bejar, diarrhea. Diarrhea. Dose of insulin infusion in calcium channel blocker, overdose. 0.5 to 1 unit per kg per hour, 0.2 to 0.3 unit per kg per hour, 10 to 15 unit per kg per hour, 15 to 20 unit kg per hour. How we treat with insulin. So 0.5 to 1 unit per kg per hour. End point sign of atropinization. Very important. I think all postgraduate must know about this. Dilated pupils, tachycardia, clear lung sounds, bradycardia. Clear lungs, fantastic. When is calcium gluconate is contraindicated? Hyperkalemia, oleander poisoning, digoxin toxicity, all of the above. Fantastic, all of the above. So with this, I think you secured the highest marks, okay? You will get the 4 chocolates. Okay, so with this, if we'll talk about poisoning, we must know what is poison is all about. So poison, by the definition itself in the textbook, this is the very clear-cut definition in the textbook. So I don't have to go much, but the Paracelsus, who is called the father of toxicology, what he says that all things are poison and nothing is without a poison. It is the dose that makes a thing not a poison. Such a beautiful definition, you see. Beautiful definition. So we have to understand that poison is very clear here inside. So when we are talking about poisoning management of the patient, we should understand that this is what's the fundamental management of poisoning. Of course, when patient comes to us, we should have to support the vital signs. I don't have to go more details about the vital signs. Second important thing that we have to look after, prevention of further poison absorption. If poison is there, we have to prevent it further, that these poisons should not absorb more. Third important thing, enhancement of poison elimination. We have to think about quickly how this poison should go out of the body. And the most again important that we have to think about whether antidotes are available with us, or if antidotes are available, whether it is appropriate that we should give at the right patient. And the another important thing is in the poisoning care, supportive care of these patients. Next. Yes. Okay. Okay. So these are the fundamental of poisoning management. The next is when patient comes to the emergency department, what we supposed to do. So the most important thing is when the poisoning patient comes there, we should not only think about the poison, we have to treat the patient as such. And we have to assess systematic approach. The first important thing, of course, ABC, airway, breathing, circulation of resuscitation. Second, decontamination. Third, we have to have some history, whether what he has taken. The fourth, as I said, prevention of re-exposure. Treat associated comorbidities or injuries. Enhanced elimination support, antidotes, some investigations, and of course, disposition of these patients. So when we talk about airway, when patient comes to us, when we talk about the patient's airway, we have to understand whether this patient airway is compromised or not compromised. Of course, if compromised, we don't have to wait for waste more time. We have to have a definite airway for these patients. If not compromised, if this patient is not compromised, then if airway is patent, then next. If sensorium is compromised, then of course we have to intubate this patient. If sensorium is altered, we have to intubate this patient. After intubation, we have to proceed with resuscitation. If patient sensorium is normal, we have to proceed with resuscitation. Next. So airway, how we will check the airway? We have to patient comes to us, we have to check the airway. We have to ensure that airway is clear. Suction, we have to suction out the secretion, whether the patient is having the, able to protect the aspiration. If not, we have to intubate these patients with cup tube. Next. So we have to understand what are the indication for the intubation. Indication for intubation, either for the airway protection or mechanical ventilation. Airway protection, we can see whether patient is having obstructive airway or laryngeal edema or bronchoria or depressed sensorium. For example, if patient is having obstructive airway, we have to intubate quickly. For example, if some patients having poison and hair dye poisoning or some other poisoning, whether we can think that patient is having laryngeal edema, or simultaneously bronchoria, patient is having OPC poisoning, having lot of bronchoria, we have to think about quickly protect the airway. Depressed sensorium, intoxication, alcohol intoxication, opioids. If patient is having depressed sensorium, we should not wait more time. Simultaneously, if patient is having oxygen failure, ventilator failure, or cellular hypoxia, we should not wait more. We can watch, but we should very fast, we have to address this airway quickly. So next, after airway, we have to check their saturation. Always we have to provide some non-rebreathing mask, oxygen, observe breathing pattern, how the patient is breathing. What is the adequacy of breathing? And we have to ventilate if necessary. Next. So ventilate failure, when we have to failure, when we think that this certain poison can cause respiratory muscles weakness or respiratory depression, or certain poison can cause continuous seizure, then we have to ventilate these patients quickly. Next. Hypoxia, when the patient can have disruption of oxygen absorption or cellular hypoxia. So particularly carbon monoxide poisoning, cyanide or hydrogen sulfide, these patients having a cellular hypoxia. So these patients require ventilation as early as possible. Next. Bronchospasm due to either direct irritant injury or pharmacological effects due to inhaled gases or aspiration, particularly insecticides, when then we have to think about ventilate these patients quickly. So after airway and breathing, we have to think about these patients. What about their heart rate, blood pressure? We have to monitor these patients. We have to give adequate IV fluids. If fluid is not enough, we have to think about inotropes. Next. So this is a synonym. These patients can come to us with hypotension. If the history is available, we can think about this synonym, crash. This patient can come with hypotension. If this patient has taken clonidine, Respirine, or antidepressant, sedative, or heroin, opiates, these patients can cause crash. So this patient can come with hypotension. Simultaneously, patient can come with bradycardia. Bradycardia means synonym paste. For example, if patient is taken beta blocker, propranolol, or anticholinergic drugs, clonidine, ethanol, digoxin, these patient, if history will find, then this patient can come with bradycardia. Simultaneously, tachycardia. The
Excuse
synonym
me
is
for
fast.
interfering. Please, people sitting behind, keep quiet. You concentrate either the speaker or go out.
No problem. We can ask some questions, then everything will be silent. This is the best way in the CME. Tachycardia, if patient is having fast. For example, if patient has taken free base for cocaine or anticholinergic, antihistamine, or sympathomimetic or theophylline, patient, this synonym is fast. Right? We can know from the history and patient's clinical examination tachycardia. Next. So history is very important when we talk about poisoning. So we have to ask the patient or relative. If patient is conscious, then you can ask the patient's history, and most of the time we have, of course, we don't get the right history, correct history. So we have to understand what is the patient's mental health, whether patient had a previously any suicide attempt, or if there is any overdose, reason for overdose, or we have to find whether patient is having any additional injuries. There are many studies that patient will not tell the right history or correct history in poisoning or intentional overdoses patients. When it comes to us, they will not tell. Even 2 days, 3 days, I have seen a couple of patients from Madurai, up to 4th day also they didn't tell the right history, and patient was intubated, extubated. So even the study says more than 70% patients, they will not tell the correct history. Next slide. So when we think about poisoning, now you can see this slide. It's anything we can see here in this slide? We don't see very clearly. Next. Now, if you see here in this slide, same slide, but if you can see there, what we can find? You can appropriate here. Anything is here? Can you see here? This is a snake. Isn't it? This is a snake. Yeah, this is a snake. Now you can see same picture, but when we see very, next slide, very deeply, we can find there is a snake, and exactly same as in poisoning case. When you take repeat asking to the patients, to the relatives, you will find the story behind all poisoning patients. Only I think, like neurology, you have to have more, depth of here history taking or clinical examination when you treat poisoning patients. When we should have a doubt? Absolutely, when the patient having altered sense level of consciousness or unexplained signs and symptoms. When the patient unexplained, patient is not telling, if there is no smell. Of course, we have seen many patients where most of the investigations are normal, then we find the patient is having poison. So next slide. So of course, this is very important. This is the first thing that we have to do it, clinical examination, vital sign, physical examination, smell or odors, skin, neurological examination, eyes, pupillary size. Next slide. So as I said, earlier we used to do the patient comes with unconscious patients, not responding. We used to have a coma cocktail. So where dextrose, thiamine, naloxone. But now as we have a bedside tests available quickly, we don't have to use this because we can do a quickly blood sugar. If patient is unconscious, we can know the random blood sugar. If alcohol patients comes with, we can think about thiamine. Next. But if you see in American Heart Association last year guidelines, they appropriately, even they have, they are asking to keep the naloxone dose as early as possible if patient is overdose. So this is an emergency drug which we can use when we can think about opiates overdose. Next slide. So after airway, breathing, circulation, now we can think about decontamination, which a very important part of poisoning management. So of course, skin decontamination, and not only the skin decontamination, we have to, next slide. We have to decontamination in small organs, small part of the body, we have to decontamination. And surface decontamination as such, we have to, follow a proper universal precautions, and gross decontamination should be done in the emergency department or priority emergency department before admitting to the ICU. And all this contaminated clothing should be collected, bagged, and properly disposed. Next slide.
Sorry to interrupt, doctor. We have minutes.
Yes, thank you. So we have to give the special attention to all the organs and small parts of the body. Next slide. and how this has to be washed properly in the emergency room or before putting the emergency room. And gastric decontamination usually we should do where induced MSCs or gastric lavage. Activated charcoal plays a very important role, whole bowel irrigation or endoscopic removal. So induced MSCs, of course, no longer has been used, and gastric lavage is very important, and it should be used within, it is very effective within 1 hour. And even Indian scenario, we should use whenever patient comes, if it is indicated, we should do the gastric lavage. So the procedure is very simple because we have to follow the gastric lavage properly. Otherwise, there are a lot of complications, particularly in the pediatrics age group. Aspiration is very common. And earlier, we used to do the gastric lavage like this, a big, the tube, but no longer now. We are using like this. We can use the rice tube. This is what we used when I was in CMC Vellore. We used to do, 15, 17 years back. So stomach has to be, we have to understand there's maybe contraindication in when patient is having corrosive poisoning or hydrocarbon poisoning on unprotected airway. Patients should not do gastric lavage when GCS is low, or once we have to protect the airway, then only we have to do the gastric lavage. So gastric lavage complication can be this. Patient can also have a hypoxia, bradycardia, and cardiac arrest. So activated charcoal, it is a highly absorbent and universal antidotes. And multi doses of activated charcoals are very useful. There are many studies, and usually we give 1 gram per kg body weight. 50 to 60 gram can be used, and it is available in biscuit, chocolate, and powder forms. And it should be useful, and it should be kept in every emergency department. Charcoal also doesn't absorb. This is a synonym. Charcoal, caustic, corrosive, heavy metals, alcohol, chlorine, others, and lithium. All these substances doesn't absorb charcoal. So there will be some adverse effect. Constipation is one of them. Gastric distension and vomiting may cause. Catarrhatitis, we can magnesium sulfate or sorbitol can be used. Whole bowel irrigations, peg leg, when the patient can have heavy metals or substance release, we can use. Enhanced elimination, particularly salicylic poison, and extracorporeal removal. And this modality can have hemodialysis, charcoal hemoperfusion, peritoneal dialysis, or plasmapheresis. All these things, if you have, probably we can, extracorporeal removal can be done. So CRT also can be used when the hemodialysis or hemoperfusion is indicated, but is unavailable, or hemodynamically instability patients CRT can be used. So antidote is just like Krishna in Mahabharata Yuddha. Mahabharata, antidotes can be like a Krishna. So you can have antidotes. All these substances, antidotes can be kept if you are getting this type of substances having patients in emergency. For example, if paracetamol poisoning, N-acetylcysteine, and beta blockers, glucagon. Next slide. Iron, deferoxamine, opiates, naloxone, as I said, antidepressants, soda bicarbonate, all these things. Not necessary that we should remember all. We can put a poster and keep in an emergency room or ICU, so that not necessary that we should remember all the doses. We should keep in a poster, or you can follow, but these are the life-saving drugs. Today morning, I received a patient with 50 tablets of antidepressants, and we have within 5 minutes after the soda bicarbonate, and yesterday patient received opiates, naloxone given, and patient not required intubation. Next slide. So remember 3G when we are dealing with the poisoning patient. First is CVG, ABG, and ECG is must. for apart from other investigation, renal function test, toxic screening it with available X-ray. X-ray is very few if patient is having tablets, overdose, or any foreign bodies, particularly body packers. Or not only that, we have to think about poisoning patients, we have to think about whether this patient having some associated complaints, whether patient having trauma or chronic illness or environmental. So supportive treatment is very important. We have to think about not only the toxin, we have to correct the electrolytes imbalance, correct the acid base imbalance, and correct, of course, hypo and hypothermia. So according to the patient condition, according his GCS, according his blood parameters, we have to think about whether this patient should go to ward or ICU or ventilated. So these are the criteria for ICU admissions. If this patient is fitting to this criteria, and definitely this patient should be admitted in the ICU, and never. So we should discharge without the psychiatric counseling. And of course, each overdose patient should be admitted at least for 6 to 24 hours in the hospital. So misdiagnosis is a potential medical legal pitfalls. We may do wonderful, but when we miss something, it is a problem to our profession. So before I end, so I will ask you that never withhold intubation if the patient is in distress in poisoning, because this is how something different. Poisoning, patient may talk to you right now, but after 5 minutes, patient can have bradycardia, hypotension, and better we should tube this patient as early as possible. Multi-doses activated charcoal study says that it has the role if it is indicated. Supportive care is the most important measures in poison patients, not only antidotes, supportive care. When you doubt, don't discharge this patient from the hospital, and not necessary that we should know everything in poisoning. It is a very vast, it is another medicine, not necessary we should know the necessity, full doses, antidotes, how to treat. Definitely you can consult with the toxicologist or poisoning center. I'm glad to share that, next slide. Glad to say that I am one of the member of the toxicology poisoning team in Tamil Nadu by the National Health Mission. And probably the government of Tamil Nadu soon starting 104 as a poisoning helpline, so that anywhere all over Tamil Nadu can, anytime they can call. So any type of information they can give. And I'm glad that we have released this book, Clinical Toxicology, only case-based approach. Whatever we have seen, the patients, clinical patients, and we have put in a textbooks, and we have started a fellowship in clinical toxicology course under the Indian College of Emergency Medicine. And this is a one-year course, online course. So with this, I would like to thank again the organizing team for giving me this opportunity.
Thank you very much, sir, for your excellent lecture. Now, audience, your invited questions.
Okay. So most of the time we are using, dialysis. If patient is required dialysis, patient goes to the dialysis quickly, if required.
Yeah, few questions. See, one of the most common poison in our country is organophosphate poison. How often you advocate the stomach wash and?
How often?
Yes.
Yeah. Most of the time, if organophosphorus poisoning patient comes, if we know the history, then we should. In fact, this is the guidelines is coming that all poisoning patients, if there is no contraindication, we should give the gastric lavage.
See, what I do is, I always every second hourly stomach wash. For
Every
an
second
organ-
hourly.
Yes, for organophosphate poisoning. I don't know whether I'm right or wrong, but it is my concept. Because, see, the organophosphate is sometimes is getting absorbed and get deposited in the fatty tissue and re-excreted into the stomach for next 24, 48 hours or something like that. Therefore, my policy is to do a stomach wash every second hourly. Do you agree with that?
Not necessary, sir, because if the gastric
if-
lavage comes clear fluid, after that you can give the charcoal. So after giving charcoal, there is no point of doing the gastric lavage.
No, activated charcoal is good, no doubt in that. But how many hours after the injection of poison?
Okay, your question was after how many hours patient comes? Okay, so then anytime patient comes to the emergency, because usually in India, the patient will not come after 1 hour or 2 hours. If it is comes, we should give. Otherwise, the guidelines is coming now after many studies from CMC, MMC, Stanley. What we are telling that first time when patient comes to emergency or hospital, we should give the gastric lavage.
That's
Not
right.
necessary that 2 hours or 4 hours or 6 hours. Why? Western countries, there are many literatures. They say we don't require the gastric lavage. Even Amrita, Dr. V.V. Pillai, Professor V.V. Pillai, they don't give gastric lavage. Many, poisoning. But in Indian context, not only patient take only OPC, they will take biryani nicely. They will take alcohol. They will even take something else. So when you do the gastric lavage, that's what we have written. Even up to 12 hours, some sustained release. Some medicines, even some patient with OPC, with medicine, with biryani, with alcohol. So it is better to give the gastric lavage when patient comes to the emergency, no problem.
Okay, you made some statements about the American and see regarding as a neurologist, India is a different country. Okay, India is a heterogeneous country. Every 100 kilometers, everything changes. So no single policy is applicable to the whole country.
Absolutely.
Am I right?
Yes.
Yes.
Even the snake bite.
There was a statement that what is applicable to Ford Motors is applicable to America, right? Because Ford Motors is a conglomeration of all the, but whereas India, every 100 kilometers, the language changes, food habit changes, climate changes, culture changes, everything changes. There were no single policies applicable to.
Absolutely. But we have to make a, some
Am I
type
right,
of
sir?
guidelines. Absolutely. You are correct.
And regarding intubation, what is the indication for intubation? I think if you feel like whether the patient requires intubation, do it.
Absolutely. Correct. If any doubt, you intubate the patient.
There is no doubt. Whether this patient requires something like LP, where this patient requires a lumbar puncture, if it is necessary, do it. Where
Correct.
this patient requires a tracheostomy, do it. Because an elective intubation is always better than an emergency intubation.
Absolutely. That's what I said, that we should not wait. We should intubate,
Yes.
watch. We should not wait.
And
So
sir,
if-
recently, I got a patient with arcamine poisoning. 20 tablets of clonidine. And we managed with the naloxone. Am I right?
Yes.
100 microgram per hour or something like that.
Yes.
Because that's one thing, because it's very, very rare.
Patient will be,
Yes,
GCS would have improved.
yes. Thank you.
Within
Thank you.
2 to 5 minutes, GCS will improve.
Thank you for
Not
your
necessary.
excellent lecture and contribution. Thank you.
Thank you, sir. Thank you.
How often you get severe hypoglycemia in this as a
Severe hypoglycemia with diabetic patient or patients with poisoning?
diabetic patients, severe hypoglycemia. You do not know
Nowadays,
unless there is a
nowadays
history.
patients are very smart and good that our education and awareness is very good. Very rarely we are getting now hypoglycemia. Even many primary center also, because patient they knows. Now, good that its credit goes to the doctors. Credit goes to the doctors, very rarely hypoglycemia. But hyperglycemia, diabetic ketoacidosis song is plenty, particularly type 1 diabetic or type 2 diabetic with with sepsis. But hypoglycemia is very rare.
Thank you, sir.
But Arise study says 6 countries it was done. Out of 1,180 patients, there were almost 67 severe hypoglycemia. 67.
Thank you, sir. So since this is a hybrid meeting, we have one question from a Zoom meeting also, sir. Dr.
So
Muthuram Subramaniam has asked, can you tell the antidote of hydrogen sulfide poisoning?
The list is there.
Okay. I think he missed it, I think,
The
sir.
listed
Thank
is
you.
there.
Sir, and also another Dr. Gifty has asked a question. Role of IV hydroxycobalamin in cyanide poisoning.
Yes, there is a role.
Thank you, sir. Us and the chairpersons, we request Dr.
Just
Sundaram.
once again,
Yes,
if a patient can cough very loudly, and can you send out the anesthetist? Will you avoid intubation or will you wait and watch?
Cough is very loudly. I think
I will keep the anesthetist in the next room.
Observation. When you
Yes.
have a doubt, intubate or observe closely.
there is no harm to intubate any tube patient. If any doubt, that's what I said. If any doubt, if I will have a doubt at that particular time, I will intubate the patient, no problem. And after few hours, I can
You
extubate
can
the
always
patients.
remove it.
But if not intubate, suddenly patient go to the bradycardia and cardiac arrest. And why I should do more resuscitation? Already the patient is sick. So intubation is just like NGO to the heart. So better to intubate than losing the patient.
It's a good relaxation to the treating physician and good learning for the patient who has consumed something.
Absolutely.
mentor to our speaker. We also request our speaker, sir, to hand over the moment to both the chairpersons.
Next session. Speaker. We move on to our third session. We request Dr. Vasan, laparoscopic surgeon, Tuticorin, Dr. Ramasubramanian, medical gastroenterologist, Tuticorin, who will chair this session. We request you, sir, to introduce the speaker.
Good morning, senior professors. At the outset, I'd like to thank Dr. Arulrhaj sir and his team for inviting me for this August function. And it's always a pleasure to come for his annual CME. Actually, our next lecture is going to be on surgical abdomen and Pandora's box. Actually, I don't know what is the idea of this title? Because as far as I know, in Greek mythology, Pandora's box is always not a mystery. Actually, when they open, all the evils came out of it. And when Pandora closes the box, the only thing which was left inside the box was the hope. And all the other evils that come out of that box. So probably when the surgeon opens, I don't know what is the relevance of this title to this talk, but generally it is being used as surprises. We go in for thinking it is going to be one diagnosis and we find something else. That is that is why this term is being used, but according to Greek mythology, it is a different story together. And a lot of interesting things are there about Pandora, but already the time is running out. So our next speaker is going to be Dr. Bennett Doraisamy, who's a very close friend for me for more than 15 years. He is HOD of Department of Surgical Gastroenterology, Tirunelveli Medical College. And he is a very good academician, a very good surgeon, and always easily approachable. He has papers in various national and international journals and various research projects going on under his guidance in Tirunelveli Medical College. So over to Dr. Bennett for the talk.
Thank you, sir. Good morning to all. I thank the chief, sir, and the co-organizers for giving me the opportunity to stand before you. Straight away, we'll go to the chapter. So, surgical abdomen, yeah, Pandora's box. Next. So, in Greek mythology, the character Pandora had a large box. It contained all the troubles of the world. When she opened the box, all the evils of the world turned her as they escape. Next. So, why is abdomen a Pandora box for surgeons? One never knows what will come out of it when one opens it. We expect one thing, many times unexpected thing comes out. We expect one thing, then nothing comes out. So even well-experienced surgeons are constantly amazed at the variety of pathology they have encountered on opening a patient's abdomen. In spite of so many new investigations at our disposal, like ultrasound, CT scan, Yes. So instead of all investigations, we are still in a dilemma to diagnose. The principal symptoms of abdominal condition is pain abdomen. The difference diagnosis is extremely wide, and definite diagnosis is often very difficult. This is due to the many different organs inside the abdomen and the potential for referred pain from outside. Next. So we are having case capsules. Number one, that 60-year-old female with lower abdomen, pain for 4 days, and generalized fatigue 3 days, and abdominal distension 3 days, and vomiting 3 days, and obstipation 3 days. There's history of bleeding PR on and off, and no previous pain abdomen or surgery. Then on examination, there is lower abdominal distension, tenderness lower abdomen, no obliteration of liver dullness, and bowel sound sluggish. Then X-ray abdomen is not much helpful. Next. So ultrasound abdomen, excessive bowel gas limits detailed examination, GB and pancreas not assessed, and mild fluid noted in the peritoneal cavity, and distended and fluid-filled bowel loops with a diameter of approximately 4 centimeters. So our provisional diagnosis is probably intestinal obstruction. Next. So serial examination, distension and pain persisted, no bowel movements, bowel sounds absent, and we have decided to take it for laparotomy. Next. So what we found is different from what we expected. That is duodenal perforation and peritonitis. Next. The case to 45-year-old female with pain abdomen 5 days, with distension 5 days, and vomiting 2 days. There is a previous history of laparotomy for hysterectomy. So examination, generalized abdomen distension, tenderness, and bowel sounds exaggerated. Next. So X-ray abdomen, we have seen the X-ray abdomen, we can see the dilated bowel loops. Next. So ultrasound abdomen, dilated small bowel loops measuring 4.7 centimeter in diameter, and minimal free fluid noted in the pelvic cavity, and urinary bladder is empty. So because of failed conservative management, we plan for laparotomy. So already there is a previous history of surgery and a scar. Surgeons always thinking in terms of adhesive obstruction. Next. So the intraoperative finding is there is growth in the ascending colon. So we have planned for right hemicolectomy. Next. So case 3, 40-year-old female, deaf and mute, with the brought with complaints of abdominal distension and vomiting for 5 days. Next. So on examination, there is abdominal distension, there is no features of peritonitis, and perirectal impacted stools and enema, patient passed stools, and distension slightly reduced. X-ray abdomen, air fluid levels in small bowel, and ultrasound, no significant findings other than dilated bowel loops. Next. So diagnosis is interstitial obstruction. However, patient passes flatus and intermittent loose stools and still complains of pain abdomen. But the examination that's guarding in the right iliac fossa, and ultrasound, repeat ultrasound shows there is collection in right iliac fossa. So intraoperative findings, gangrenous appendicitis with pus formation. So we have suspected intestinal obstruction, but it landed up in appendicitis. Then case 4, a 30-year-old obese female, known case of PCOD, complaints of pain abdomen, more in the lower right quadrant, 2 days, and vomiting 1 day, and fever 1 day, and history of irregular menses. Next. On examination, patient's febrile tachycardia and abdominal tenderness present in the right iliac fossa, no guarding rigidity, and bowel sounds present. So lab investigation shows elevated TLC, normal LFT and RFT, and ultrasound of abdomen, a non-compressible tubular structure with the maximum internal diameter of 6 mm with surrounding fat stranding noted in RAF, and probe tenderness present. So we have a provisional diagnosis of acute appendicitis and plan for lap appendicectomy. Next. But the finding is appendix is normal and there is a twisted ovarian cyst. Next case. So case 5, 30-year-old female with complaints of pain in the right iliac fossa since 5 days and bilious vomiting 2 days and fever 1 day. No history of similar complaints in the past and not a diabetic or a smoker. Next. A clinical examination, tachycardia and tenderness RAF and the abdominal distension and bowel sounds sluggish. Next. So laboratory investigation, elevated TLC, dearranged RFT and normal LFT and serum amylase normal. So X-ray abdomen features suggestive of early ileus. Next. So ultrasound abdomen, GB normal, pancreas obstructed with gas or dilated small bowel and larger goose with the features of ileus and moderate free fluid noted in right iliac fossa. So diagnosis acute appendicitis with the appendicular perforation and pair of findings, there is pus collection in the right iliac fossa, but appendix normal, then the pus appears to come from upper abdomen. Then postoperative CT shows that is necrotizing pancreatitis. Case 6, it's a 46-year-old female, severe crampy pain abdomen, 3 hours, nausea and 1 episode of bilious vomiting, chronic smoker and the history of drug abuse and insignificant menstrual and obstetric history. The clinical examination, pulse 76 and BP normal and periabdomen soft, no distension, no guarding or rigidity or bowel sound normal, PR normal. Investigation, normal TLC and normal RFT and LFT. Next. Erect X-ray abdomen is not much helpful and ultrasound normal study. So the diagnosis with the Korea acute gastritis, patient treated symptomatically and symptoms subsided, discharged after 2 hours observation. Then patient returned 12 hours later with severe crampy abdominal pain, bilious vomiting and abdominal distension. So clinical examination, tachycardia, periabdomen distended, tenderness present lower abdomen, no guarding and rigidity and PR normal. In lab investigation, total count elevated, LFT normal, RFT deranged, and LDH 562 and amylase 322. And X-ray abdomen, there's multiple fluid levels. So ultrasound abdomen, dilated fluid build small bowel loops with the moderate number of free fluid in the peritoneal cavity. So we have to rule out the intestinal obstruction. So CCT scan dilated fluid filled small bowel loop with strictures narrowing noted in the terminal ileum, moderate fluid in the abdominal cavity. Next, so we can see the terminal ileum with the acute small obstruction due to ileal stricture. Plan for laparotomy. Next, so intraoperative finding, that is segmental ischemia of terminal ileum. Next, case 7, 36-year-old woman with intermittent lower abdominal pain, nausea and vomiting, family history of hereditary disorder, but records are not available, no significant past history. Next, tachycardia, vital stable, afebrile, lower abdominal tenderness, no guarding rigidity and bowels present. And TLC elevator, RFT and LFT normal, serum amylase normal, and direct X-ray is not significant. Next, use the abdomen normal study. Patient managed conservatively with the antispasmodic. Patient continued to have pain abdomen which was worsening and intolerable. Repeat examination, there's a tachycardia plus and perabdomen soft, diffuse tenderness, lower abdomen, no guarding rigidity and bowels present. Then patient catheterized and urine found to be of dark reddish brown in color with the previous history of unknown hereditary disorder. Our diagnosis is next. There's acute intermittent porphyria, that urine probably was sent and found to be positive, and patient managed according to the medical team. So not all pain abdomen patients have an underlying surgical cause. The surgeon should always remember that many medical conditions can masquerade an acute abdomen. Next. Then 6-year-old girl, case of RTA, diagnosis of grade 2 splenic injury with hemoperitoneum on IV contrast CT, hemodynamic is stable, persisting abdominal distension and pain. Next. So serial examination, abdominal distension and no feature of peritonitis and bowel sounds absent. X-ray abdomen, no free air under diaphragm, and ultrasound, free fluid in abdomen with dilated bowel loops. Next. Then repeat CT, that's moderate hemoperitoneum and grade 2 splenic injury and few interbowel air packets noted. So because of the air packet, we have planned surgery and opened, and we are able to find the jejunal perforation. Then case 9, 39-year-old female with the complaint of epigastric pain and retching 2 days, and history of non-bilious vomiting past 2 days, history of fever 4 days back, treated with the steroid injection at a local hospital, and history of decreased appetite since one day, past history COVID positive 3 weeks back, and pulse 58 per minute, SpO2 99, room temperature, and afebrile, soft epigastric tenderness and right appointed tenderness present, bowel sounds normal. Next, day 1, hemoglobin 10.1 and LFT total bilirubin normal, and SGOT and SGPT elevated and the ALP elevated. Serum amylase normal and LDH 1624 and D-dimer 350, PDNR normal, COVID negative and dengue negative. Next, day 2, that ultrasound CBD normal, and that there is a gross increase in the SGOT and SGPT level and ALPP. So what does the deranged liver enzymes indicate? So ultrasound abdomen, GB wall edema, hepatomegaly, and minimal ascites, and CT thorax, that is bilateral minimal pleural effusion. Next. So that CT abdomen shows mild hepatomegaly with periportal hyperdensity and diffuse GB wall thickening, minimal ascites, and bilateral minimal pleural effusion. So patient was suspected as post-COVID sequelae, that is post-COVID liver cell failure, and we have referred the patient to Madurai from Tirunelveli. Then what's the diagnosis? So meantime you get the report for hepatitis B is already negative, and antihepatitis A IgM was positive on day 3 in Tirunelveli, but already patient went to Madurai, and patient managed conservatively with IV fluid supportive management, and patient recovered and discharged. Case 10, 21-year male, lump in the right upper quadrant abdomen, 3 years, gradually increasing size and occupying right hypochondrium, lumbar and epigastric region. Also complaints of vague abdominal discomfort over the area. No other significant history. So clinical examination, vital stable, has a huge intra-abdominal lump as shown in the picture, and laboratory investigations normal. Next. So ultrasound revealed a huge cystic lesion, 15 centimeter, arising the right lobe of the liver with suspicious daughter cysts inside it. And ELISA test for echinococcus granulosis is positive. Next. With strong suspicion of hydatid cyst, CT scan was planned. Cyst arising from the right lobe of liver is confirmed. Next. So this is our final perioperative diagnosis is hydatid cyst involving right lobe of the liver and plan for laparotomy. So laparotomy, we are seeing a giant right-sided hydronephric kidney due to pelvic ureteric junction obstruction. So we have done a nephrectomy and patient was discharged on 8th postoperative day and patient is doing well. Next. So case 11, 40-year-old male, complaints of pain, right of hypochondrium, epigastrium 15 days. Also complaints of indigestion, early satiety, known smoker and occasional alcoholic. Past history is insignificant and vital stable, periabdominal soft, mild epigastric tenderness and no distension bowels and splash. Laboratory investigations normal. So ultrasound, multiple hypoechoic foci with posterior acoustic shadowing suggestive of gallbladder stones and gallbladder walls normal and CBD duct and CBD cystic duct and CBD normal and cholelithiasis, and we that patient was planned for laparoscopic cholecystectomy. Next. So patient underwent laparoscopic cholecystectomy and had uneventful postoperative recovery and was discharged, and patient returned after 20 days with complaints of heartburn, epigastric pain and early satiety. So upper GI endoscopy planned. So in the upper GI endoscopy, we can find a growth in the stomach, which is missed before lap cholecystectomy. So never treat the patient based on investigations. If an endoscopy was performed before the first surgery, this could have been avoided. So this may account to medical negligence. Next, a 40-year-old male presented with complaint of pain in right iliac fossa since 20 days, loss of appetite 10 days, and history of 1.5 loose stools 10 days, chronic smoker and alcoholic, no significant past history. Next. So clinical examination, vital stables, afebrile and periabdominal soft tenderness, right iliac fossa, no abdominal distension, no guarding, no palpable mass, and bowels present. Next. So lab investigation, hemoglobin 9.8 and TC 30,100, leukocytosis and LFT and RFT normal. So ultrasound, a non-compressive tubular structure of maximum diameter 7 mm in right iliac fossa fast standing in the adjacent mesentery and omodum related to early mass formation and minimal fluid collection noted in RAF and dilatation of 10 mm ileal loops noted. So impression acute appendicitis with early mass formation. The plan for open appendicectomy. Next. So intraoperative finding that see a cecum causing obstruction of the appendix lumen and causing appendicitis. The take-home message is not all appendicitis are straightforward. Always correlate with patient age and clinical findings, and always calculate the mental score and correlate with the clinical findings. Then 50-year-old female, sudden onset severe abdominal pain since 1 day, no history of vomiting, no altered bowel habits, no significant fast history. Next. Tachycardia and afebrile and the abdomen soft, non-tender, no guarding or rigidity, and laboratory investigations normal. Next. No significant abnormality in ultrasonogram. Patient managed conservatively with the antispasmodics and admitted for 24-hour observation. Patient developed severe abdominal pain the next day early in the morning, 1 episode of bilious vomiting and abdominal distension, and examined diffuse tenderness, lower abdomen, no guarding or rigidity, bowels and sluggish. Next. Erect extra abdomen shows features of intestinal obstruction, and USG abdomen, grossly dilated fluid filled small bowel loops with to and fro movements, suggestive of acute small intestinal obstruction, moderate fluid in abdominal cavity, and CT abdomen dilated fluid filled small bowel loops with diameter of around 4 centimeters with no obvious transition point. There is edema of the bowel wall and the adjacent mesentery, moderate free fluid in the peritoneal cavity. Next, we can see the CT with the edema and fluid inside the abdominal cavity. So intraoperative findings that the acute mesenteric ischemia with the whole bowel was gangrenous because of ischemia. So the discussion. So why diagnosis is difficult in acute abdominal condition? That is, the history may not be forthcoming or not reliable. Then delayed presentation. The patient will go here and there and take native treatment and come to the hospital in a late stage, so delayed, then atypical presentation, then these peritonitis features may be masked when the patient take analgesics before diagnosis. Next. So why diagnosis difficult in acute abdominal condition? The X-ray free air under diaphragm is not in all perforation cases, and X-ray evidence of obstruction not always adhesive. CT abdomen cannot be done in many acute abdominal cases when you are taking the emergency. Then diagnostic laparoscopy cannot be done in all acute abdominal cases. Next. So does experience help? For over 30 years that I have been opening up patient's abdomen, I am constantly amazed at the variety of pathology I have encountered. Surgery never runs out of suspenseful surprises. The last operation that the surgeon performs on the abdomen before retiring, he might be see something he has never seen before. So always is a suspense. Next. So the take-home message is no shortcuts to detailed history and examination, and decide whether it is a surgical abdomen. Serial assessment of clinical findings and correlation with investigation is more important. Next. Rule out pancreatitis in all acute abdomen. Rule out perforation in all acute abdomen. Rule out causes outside abdomen, and not necessary to make an exact diagnosis, though we should be aware of the possibilities. Next. So at the end of all this, what the mind does not know, the eyes cannot see. Never have a tunnel vision. To become a great surgeon, you have to be a good physician. Thank you.
Thank you, Dr. Bennett Tresami, for your excellent presentation. You have a series of cases. So as you all know, this abdomen is a Pandora's box. So many times we have dilemmas in diagnosis, whether to open or not to open, whether we have to go for a laparoscopy or laparotomy, what is the incision, especially in females of childbearing age groups. Always you have to ask the LMP, and always you have to see while doing laparoscopy, you have to see the pelvis. As you have seen this twisted ovarian cyst, sometimes we will able to see the ectopic gestations, whether the patient is married or unmarried, all these things. So always you have to see the unexpected things. Sometimes we have to. So depending upon the situation, we have to act. We may think it is appendicitis, it may be ectopic gestations. Depending upon the status, marital status, and whether he has completed family or not, we have to do the surgeries or the medical management. I once again thank the organizer for having given me this opportunity. Thank you.
I'll just add one more interesting case to your wonderful list, which comes from enormous experience. We have learned by experience and not by books. While I was in ESI Coimbatore 1970, midnight, a policeman in mufti comes and waiting for his turn for acute abdominal pain. The doctor was delaying it because he was attending to other patients. He slaps the doctor powerfully, and the doctor goes out of his chair and telephones me as the head of the department to make a police complaint about this policeman in mufti. I went and found the policeman sweating profusely and misbehaving with other people in the OP also. And I palpated his abdomen. It was loaded. There was a big swelling. So we admitted him. I catheterized the bladder. Large amounts of urine was there. He was sweating profusely. And still there was a big lump in the abdomen, which according to me was retroperitoneal. Blood glucose was very low. It was only 20, 30 like this. Repeatedly I did. I remembered a sentence in surgical textbook, which all of us read, Bailey and Love. Small sentence. retroperitoneal fibrosarcomas present with acute hypoglycemia due to insulin secretion. Next day morning, night, of course, he threw a fit, which was hypoglycemic seizure. We managed with compost. We didn't do any investigation because I am sure investigation would have misled us somewhere else. We would have found a hepatic cyst or a renal cyst and would have gone elsewhere. Dr. Raman Kuti, general surgeon, we canceled the clinical meeting, opened the abdomen straight away. There was a huge mass retroperitoneal fibrosarcoma can present as acute abdomen with hypoglycemic neurological complications. Specimen is still there in Coimbatore Medical College Hospital. Sometimes a good teacher can help.
Thank you, sir.
So just wanted to tell about one small case. This happened during my internship in JIPMA. Middle of the night, 11-year-old boy comes with features of intestinal obstruction, and clinically we diagnosed intussusception. And immediately we opened. Night we allow only the senior resident as the team leader for duties. He opened, he palpated the bowel, and he said a lot of worm balls are there. So immediately we informed our assistant professor. He said never open the intestine if you're suspecting intestinal worms inside, because it will cause a fistula, it will not heal. So reduce the intussusception and come out. And next day morning, the boy was all right. The third day post-op, I was doing the dressings. Then he said, we are actually that time we have only this piperazine citrate for worms. So next day while doing the dressing in the room, he said he's feeling something coming out of his anus. So I took him inside and I found there was a polyp which was coming out. Immediately it struck me. I look at his mouth. We saw the blue line in the gums. So it was a case of familial polyposis causing intussusception. And immediately we investigated. And the next duty, another similar boy came for admission with features of intussusception. I received him. Then I asked him history. He said his brother is, cousin brother is already admitted with similar complaints few days back and underwent surgery. So this case I'll never forget because of the uniqueness and because I was able to diagnose a familial polyposis at that time. So it's really a Pandora's box. You will not, the moment the decision-making surgeon has to be aware of so many things when he opens the abdomen and should not burn our fingers unnecessarily. Thank you.
Thank you, sir. If there are no more questions, I request Dr. Ram Subramaniam sir to hand over a memento to our speaker, Dr. Bennett sir, please. We also request our speaker to hand over the mementos to both our chairpersons, please. அது அப்படியே எடுத்துருங்க. Thank you very much, sir. We shall now move on to session 4.
I kindly request Dr. Vasan, laparoscopic surgeon. Sorry. I kindly request Dr. Bethukani ma'am, consultant obstetrician and gynecologist, Veeramani Hospital, Tuticorin, Dr. Aarti Kannan, physician and diabetologist, Tuticorin, who will chair this session and introduce the speaker.
Good morning, everybody. It's a great pleasure to chair the session on gestational diabetes. First of all, I thank Dr. Arulrhaj sir, Dr. Aarti, and Dr. Archana for giving me the greatest opportunity to chair the session. Today's topic is gestational diabetes. Because of the sedentary lifestyle and Swiggy and Zomato, the incidence of gestational diabetes is increasing like anything. As the previous speaker was talking on toxicology, he was telling, even while consuming the poison, they are taking biryani along with poison. So the intake of biryani and barota, it is increasing like anything. And during pregnancy, even if we tell the patient that he should decrease the intake of carbohydrates, the family members don't listen to that. They think that the pregnant women's desire should be fulfilled and they feed them like anything. So there are real problems in managing the gestational diabetes. Today we have got Dr. Kumaravelu sir for enlightening us regarding the management of gestational diabetes. He has been awarded a honorary professor in New Delhi and is Vice President Endocrine Society of TN. He is a course director in FCE organized by MASCGP. He has organized many national and international conferences. He has published in many national and international journals. He has contributed a lot to revise the IAP growth chart, and he has undergone special training in islet cell transplant in USA. And he's a very busy practitioner in Madurai. He's working as an endocrinologist in Alpha Hospital and Research Center, Madurai. I request Dr. Kumaravelu sir to give us the talk.
Thank you, madam. Respected chairperson, Dr. Arulrhaj sir, Aarti madam, co-speakers and my dear friends, and respected seniors and sir, my teacher. And I'm here to talk on gestational diabetes mellitus. Next. So this would be the overview of my talk. I would discuss the definition, what exactly is this gestational diabetes, and I would try to discuss on screening, whom to be screened and when to be screened, and how exactly the patient has to be screened. The treatment modalities, why is it important to treat a patient with gestational diabetes? And if you decide to treat, how exactly you are going to treat? Monitoring is very important. Any disease or any treatment you treat, monitoring is very important. So what is the use of fetal monitoring, maternal monitoring? And I would try to conclude by case scenarios. Next. So definition of gestational diabetes, it may sound very simple. It is nothing but a carbohydrate intolerance of various degrees. It could be a blood sugar of 200 or 300, 400, of any degree of carbohydrate intolerance, which is detected first time during pregnancy. So that is by definition gestational diabetes. So people are called gestational diabetes irrespective of whether they are treated with insulin or diet, or irrespective of the perinatal outcome, which could be obstetric or neonatal outcome, and irrespective of a risk for future diabetes for mother and the fetus. And it could also include occult type 2 diabetes, which is not diagnosed before gestation. So pre-gestational diabetes basically precedes the diagnosis of pregnancy, and gestational diabetes basically precedes the diagnosis of pregnancy. So that is basically a definition for gestational diabetes. Next. So whom and when to screen? We have various screening strategies. You can try to compartmentalize patients with high risk for gestational diabetes, average risk, and low risk for gestational diabetes. High risk individuals are those with marked obesity, with personal history of gestational diabetes in previous pregnancies, patients with glycosuria, or patients with a strong family history of diabetes. So these patients should be screened as soon as feasible. So once when the pregnancy is confirmed, or these patient has to be screened, and they should be retested between 24 to 28 weeks if they are negative. Low risk are those patients who are less than 25, normal weight, ethnic group with low ethnicity of diabetes. And these patients, basically, they may not even require screening for gestational diabetes. Next. But in Indian setting, we are ethnically at a high risk for type 2 diabetes. The prevalence of obesity is increasing. The prevalence of polycystic ovarian syndrome is increasing. And we see so much metabolic syndrome even in children. So universal screening is probably required in our scenario, which means every pregnant woman should be screened for gestational diabetes as soon as the pregnancy is confirmed in the first trimester. Next. So having said this, how do you screen? Don't be carried away by so many numbers here. So as with the evidence what has been accumulating, the guidelines, they keep on changing, the numbers also keep on changing. So you can use any of these guidelines. You can use either WHO, you can use DIPSI guidelines, you can use IADPSD guidelines, you can use ADA. So it is just a gameplay with numbers. So basically you can have either one-step approach or a two-step approach. So two-step approach, finally your diagnosis revolves around the oral glucose tolerance test. So when I say oral glucose tolerances, you give 75 grams of glucose and fasting should be less than 92. Your 1 hour should be less than 180 and 2 hours should be less than 153. So the same thing has been endorsed by IADPSD and ADA. In our scenario, we use more and more of DIPSI criteria where it could be a single step approach. No fasting is required. No GTT would be required. Directly, you give 75 gram glucose. Check them after 2 hours. If it's more than 140, you can say they could have a gestational diabetes. So what I would suggest is you can use any of this criteria, whichever you are comfortable, but stick to some criteria so that it's easy for you to diagnose and substantiate your diagnosis. Next. So this is the GDM guidelines, the DIPSI criteria, which was which came into practice in 2006. Next. So I was one among the panelists in devising this DIPSI criteria. Next. So the practical approach in our scenario, as I said, since your PCOS is increasing, obesity is increasing, any women who's planning for pregnancy, I would always recommend to have a prenatal diagnosis because screen women with risk factors, women with polycystic ovarian syndrome, women with obesity, women with strong family history of diabetes. We always tend to screen them even before pregnancy. And this screening is with the 2 hours, 75 gram oral glucose tolerance test. If that is negative, then you allow them to go with the pregnancy. And in pregnancy, once when you confirm pregnancy, we advocate universal screening because this may not be feasible for every woman, but this is definitely feasible. You approach universal screening, either two-step approach or a single-step approach. Two-step approach would be to give a 50 gram glucose and check a blood sugar after 1 hour. And if it is more than 130, you go for the next step. And second step would be the oral glucose tolerance test. So if it's cumbersome, you can straight away go for a oral glucose tolerance test. If it is negative, then you screen them at 24 to 28 weeks because that is the time where you have a peak insulin resistance. And even if this is negative, then it's not necessary you have to screen for every individual. You can do a selective screening, especially when you see a woman with polyhydramnios or when you see a fetal overgrowth or when you have some maternal or fetal comorbidities, you can screen. Otherwise, more than 32 weeks, it is not necessary screening. So if feasible, do a prenatal screening. If not feasible, universal screening at the first trimester. If negative, second trimester. If negative, selective screening beyond 32 weeks. Next. So why do you want to treat? So why is it important for me to screen and why is that I want to treat? Because there is potential fetal and potential maternal complications. The fetal complications include fetal macrosomia, birth trauma, prematurity syndromes, neonatal hypoglycemia, hypocalcemia, hypomagnesemia, and various congenital anomaly. And maternal complications include your hypertension, preeclampsia, urinary tract infection, cesarean sections, and future diabetes in mother. So you have various complications both for fetus and for the mother. So it is very, very important for us to diagnose them early, and diagnosing alone may not be important. Treating is very, very important. Next. And hyperglycemia and pregnancy, many a times mild hyperglycemia can cause early growth delay. Moderate hyperglycemia might cause congenital malformation, and severe hyperglycemia can lead to spontaneous abortion. So these things may not cause a major problem because they end up with abortion. What really concerns us is your mild and moderate hyperglycemia, where the child is born with various congenital malformation or with early growth delay, which becomes a very big challenge for both the obstetrician and the pediatrician. Next. And another most important thing, suppose you diagnose gestational diabetes the first trimester, the next concern is whether to continue with pregnancy or not, or what could be the fetal complications. So your hemoglobin A1C at the first trimester or during the diagnosis, if it is less than 8.5%, your fetal malformation is roughly around 3.4, and your hemoglobin A1C more than 8.5%, your fetal malformation is high. If suppose your hemoglobin A1C is very high, the chance of fetal malformation is roughly around 37.5%. So we should really weigh our balance between the risk and the benefit of continuing the pregnancy. Next. So once when you have decided to treat, your targets for blood sugar in pregnancy is totally different from targets for treating any normal diabetic individual, because pregnancy is a time where you require a very, very tight blood sugar control. So your fasting plasma glucose should be less than 90, your 1 hour glucose should be less than 140, and your 2 hour glucose should be less than 120. So this is the target which has to be maintained. If you are looking at hemoglobin A1C, your hemoglobin A1C should be between 6 to 6.5. But remember, hemoglobin A1C may not be a very useful tool in monitoring the control in pregnancy, because even in pregnancy, your hemoglobin A1C could be falsely high or low, depending on the anemia and your varying hemodynamic circulation. So it is very useful in the first trimester. But if you are assessing a HbA1c, it should be less than 6 or 6.5. Next. So how do you achieve this target blood sugar? So first and foremost in any diabetic management is medical nutrition therapy. I may not go into this medical nutrition therapy because that itself is a very big topic to be discussed. Next. Another thing which I would try to focus is exercise is definitely important in patients with gestational diabetes. And I would always suggest exercise should be always advised in association with obstetrician depending on your obstetric indications. And up to 3 times per week or 45 minutes per session is definitely recommended. And it is advisable who are doing exercise should continue the same exercise, and the others to do walking or gentle upper body exercise. Why is this exercise very important? Because nowadays in diabetes, we are focusing more on primordial prevention. So even before the baby is born, we are trying to prevent your diabetes. There's something called fidget gene hypothesis, which basically suggests your diabetes in the future age depends on your exercise capacity in utero. For example, if a mother does a periodic exercise, mother's adrenergic drive is high. So this adrenaline crosses the placental barrier. So this causes the fetus to move it slim. So there was a very interesting study which looked at the fetal kick count. So how many times the fetus is kicking the mother. So the mother is told to count how many times the kick was there. And what was found is that the fetus which had a maximum kick in utero had the least complication of diabetes or hypertension or any metabolic complications. So how do you make the fetus do exercise in utero? So basically you have to do exercise. You have to keep walking. You have to do household work. So that will definitely activate your fetus. So that will prime your fetus for a future exercise. That is very, very important. So in pregnancy, I would say your exercise is most important than any diet, because that has a major role to prime your fetus for future exercise. So as an obstetrician, you should say if your mother is feeling more and more of kicks, which means the fetus is going to be more healthy in future. The mother is experiencing less amount of kicks. The mother should exercise herself, exert herself, see to that the baby has a more limb movement. Next, drug therapy. So drug therapy till today, insulin therapy is the cornerstone of management of diabetes in pregnancy if diet alone is inadequate. Normally we say you maintain diet for 2 months. If it is inadequate, you put them on any kind of medication. But pregnancy itself is just 8 months. When you 10 months, when you diagnose, already 2 months is gone. So in pregnancy, you cannot wait for a long. Any trial of diet therapy could be for 1 week or 2 weeks, not more than that. If it does not work, insulin therapy has to be started. And you can use either human insulin or analog. It should be used along with self-monitoring blood glucose, which should basically guide us in dosing and timing of insulin regimen. Next. So you have various insulins starting from short acting to long acting or pre-mixed insulin. So basically we try to use a combination of either short acting and a long acting insulin. Next. Most of the insulin is approved in pregnancies. Insulin requirement, again, as your pregnancy advances, the insulin requirement changes. GDM in first trimester, insulin requirement is roughly your ideal body weight into 0.7. GDM diagnosed in second trimester, it is ideal body weight into 0.8. Third trimester, it is 0.9. Because as your pregnancy advances, your insulin resistance increases. So insulin dose also would increase. If the patient is a known type 1, your insulin requirement increases by 10% during pregnancy. Patient is a known type 2. These are nothing but pre-gestational diabetes. Your insulin requirement increases by 30% in pregnancy. Next. So these are various insulin regimens which can be used. You can best would be to give a 3 short-acting insulin, which would take care of your breakfast, lunch, dinner, and a long-acting insulin if your fasting sugar is high. If 4-time prick is difficult, you can go for 3 times prick, which could be 2 short-acting and another premixed insulin. If patient finds it still more difficult, you can give 2 premixed insulin. But remember, all these regimens should be coupled with the patient's blood sugar based on your self-monitoring of blood glucose. Next. So oral hypoglycemic drugs in pregnancy, OHA were considered an absolute contraindication in pregnancy until recently, but now we have data for say even glibenclamide, we have data for metformin, and I'm sure metformin has been also extensively used. But I would still bank only on insulin because we don't have any FDA recommendation or DCGA recommendation to use oral antidiabetic drugs in pregnancy. It could be off-label indication, but still we have seen people using it. Though OHAs are made a comeback, they are yet to enter a big league. Probably after sometimes, if we have more and more data, it may also be feasible. Next. So maternal monitoring, you monitor self-monitoring of blood glucose, you monitor your urine ketones, blood pressure, urine protein. First trimester hemoglobin A1C would be useful. Now, the interesting tool which is useful in monitoring is a continuous glucose monitoring. I would say how exactly it would be useful in titrative regimen for our patient. And self-monitoring of blood glucose should be done at least 4 times a day ideal. For blood sugars are within target, you can reduce to twice a week at 28 to 32 weeks. And then it is thrice a week after 32 weeks, provided your sugars are under control. Next. Fetal monitoring, you look at the fetal size. And 18 to 22 weeks, you look for major malformation, you look for fetal echocardiogram. 26 weeks onwards, you look for growth of the fetus, you look for liquor volume. Third trimester, frequent ultrasound is required if you suspect accelerated growth. And abdominal head circumference could be a clue to suggest whether you have a fetal macrosomia and increased fetal adiposity. Next. So immediate postpartum, your treatment does not end with the delivery alone. Insulin requirements disappear in GDM once when the placenta is delivered, and it changes to pre-pregnancy levels. Diabetes will disappear in 90% of the GDM cases, and you continue monitoring for at least 48 hours after delivery as indicated. And then even postpartum, they should be monitored for at least 3 years. And then it would be a routine risk monitoring as per the any individual. Next. So just 2 cases. This is a 25-year-old female, preemie, 26 weeks pregnant. She's obese. She has a risk factor. You do a GTT for her. So this is a fasting is 100, 1 hour is 198, 2 hours is 160. So this is a cutoff. So this patient, all 3 values are above cutoff. So it is, I know this patient has a gestational diabetes by this criteria, but it is not necessary you have to immediately jump and treat because this is done with a maximum glucose load. With a normal diet, this may not alone be the same. So what I suggest this patient is you check your glycemic profile for 3 days and come back to me. Next. So I put her on diet. After 3 days, she comes to me. Your fasting blood glucose is normal. Sorry, this your fasting postprandial breakfast. One day it is 146, and one day lunch is 152. One day dinner is 1. It is just marginally elevated. So these are the kind of patient I can manage the diet. I just ask what the diet the patient was taking. I try to titrate the diet. With the diet alone, this patient can be managed. Not necessary insulin is required. Next. So this is next. Again, a 22-year-old female, second gravida, 24 weeks pregnant, routine screening. You can see fasting like the previous case, 104, 186, 184. This is the cutoff. All 3 are more than cutoff. Next. Next. So I put this patient on diet. Next. And glycemic profile monitoring for 3 days. You can see after 3 days, all fasting is normal. All postprandial breakfast is high. Postprandial dinner is high. So it is enough if I target these 2. So I would put this patient on 2 short-acting insulin, 1 in the morning, 1 in the night. Next. So this patient you treat with human actrapid or any regular insulin, 4 in the morning and 4 in the night. Next. So this is a 26-year-old female, gravida 5, 4 abortions, 46 days pregnant. She's a known case of hypothyroid and treatment with thyroxine. Earlier pregnancy, she had a GDM. You can see the fasting blood. She comes to you with fasting blood sugar of 106 and PP of 262. It's not necessary I have to do a GTT for her because this alone says she is a diabetic and your hemoglobin A1C is 8.7. So straight away, I'll put this patient on treatment. I have put this patient on analog insulin, which is 10 units in the morning, 10 units. These 2 are short acting. And this is a premix in the night. Next.
Apologies to interrupt, doctor. You have 3 more minutes.
I'll finish before that. So it is a pre-gestational diabetes which has been diagnosed. So ideally, this patient should have been treated even before she is planning for pregnancy. Next. So this is a patient. She comes with a glycemic profile. You can see everything is within the range. But what happens is she complains of post-lunch increased appetite. You can see post-lunch, her blood sugar is low, and post-prandial dinner blood sugar is high. So it's easy for me to titrate. I reduce the afternoon short-acting insulin and I increase the insulin in the night time. Next. Next. So you reduce in 6 and you increase by 14. Now she comes to you with increased appetite in the night time. She has a nocturnal hypoglycemia. Next. So what I do for this patient is, before I need something extra tool to really see what is happening. So this is ambulatory glucose monitoring or continuous glucose monitoring, which is just like a size of the coin, which can be kept for 14 days, which will give you a clear picture of blood sugar, what is happening for 14 days. Next. So you can see nighttime, this patient is having hypoglycemia, as this patient has said. You can see morning post breakfast and post lunch, this patient also has a hyperglycemia. So these two things I can titrate with diet. I tell the patient to have a split diet these 2 times. Next. And I maintain the same amount of insulin in the morning and this thing. Night, since the patient has hypoglycemia now, initially patient has a post-dinner hyperglycemia. So what I would do is, I will reduce the dose of insulin, and instead of Humalog mix 25, I may change to 50-50 insulin. That itself will take care. Next. So you can see just fine tuning it, your blood sugars are reasonably under control. And the newest thing which is coming is a time in range, which means at least 70% of the time your blood sugar has to be within the target to have adequate fetal and maternal outcome. So initially we had a blood sugar, then we had a hemoglobin A1C, and now we are talking more and more of time in range for patients with diabetes. Next. So this is my last slide. So this is a 14-year-old female, second gravida, 8 weeks pregnant. You can see the fasting blood sugar is 136, 2 hours 201. And as I said before, OGTT is not required because it itself is high. Hemoglobin A1C is 5.7. So which means this is not a pre-gestational. If it is a pre-gestational, my HbA1c would be more than 6.5. It is a gestational diabetes. I start this patient with Actrapid 4-4 and human mixer 4 units in the night. Next. So you can see the continuous glucose monitoring. You can see the blood sugar post breakfast, post lunch, post dinner. All 3 are high, and pre-lunch there is some hypoglycemia. Now, if I target this postprandial, pre-lunch I might end up with more and more of hypoglycemia. This is the place where insulin analogs might be useful in pregnancy because they have a rapid onset of action and duration of action is less. I just changed this patient to analog. Next. Instead of human Actrapid, I have just changed to no rapid. Instead of mixed, I have changed to a no mix. And next. So you can have this continuous glucose monitoring for 14 days. You see with 3 days, blood sugars are high. I change the insulin. I monitor them for the next 3 days. You can see the blood sugar is perfectly under control and time in range is 100%. This is what we are aiming for most of our patients in pregnancy. Next. So you can have everyday control also can be seen with this continuous glucose monitoring. Next. I think I'll stop with this. And just to conclude, universal and first trimester screening for gestational diabetes should be required in our population. Aggressive insulin therapy is required in most of the cases without causing hypoglycemia. And strict maternal and fetal monitoring is important to maintain target blood sugar in pregnancy. And thank you. Thank you so much.
Thank you, sir. That was an excellent presentation on gestational diabetes. The session is open for discussion.
So I want to convey one message to this audience. Most of the gestational diabetes, they come after 2-3 years with the established diagnosis of diabetes, because 50% of these people will go for a diabetes. It's a natural history. Most of these people seen by obstetrician, they fail to tell them, you have to check your blood sugar every 6 months. This message has to be conveyed to every patient who is on gestational diabetes by lady doctors.
Sir, the analogs, which analog do you prefer, sir, for your gestational diabetes?
All analogs are more or less similar. Only thing is Novorapid and Humalog is approved in pregnancy. They are class B and class C. And next short-acting analog, Apidra is there. It is now they have got the approval recently. It is always class C. And Detimer has been approved in pregnancy class B, but unfortunately Detimer is not available nowadays. And Lantus, now they have got the approval. And Tresiba, they yet to get for class B. But otherwise, long-acting, if you want long-acting analogs, Lantus can be safely used. And if you want a short-acting analog, it could be either Lispro or Aspart could be used. But still, my first choice would be human regular insulin only. Analogs, I use it only selectively whenever I find it difficult. Because though analogs might have a better control, still it's an engineered insulin. The amino acid chain is different. So though you have so many data to suggest analogs are at par even superior to this thing, but looking at the history and molecule of analog, I still use human regular insulin for all my patients. If the blood sugars are not under control, I use analogs sparingly, but that's not my first choice in pregnancy.
Hypoglycemia is less or more, sir?
Madam,
We are
if you
preferring actually
educate the
analog for that
patient,
only, sir.
adequately, many times hypoglycemia is just a match between your insulin and the diet. If you are able to maintain that adequately, usually it may not cause a harm. But hypoglycemia and pregnancy usually does not harm the fetus. Hypoglycemia and pregnancy, basically, your fetus is a saprophyte. It sucks whatever glucose it wants, then only it goes to this thing. We have so many data which suggest hypoglycemia may not be dangerous to fetus, but if you are able to maintain euglycemia without hypoglycemia with regular insulin, that is the best, which usually I am able to do it.
Thank you, sir.
Doctor, we have a question from Dr. Muthu Ramasubramanian. The question is mechanism of fetus coping with tight glycemic control.
Fetal?
Mechanism of fetus coping with tight
Fetus
glycemic
coping, yeah.
control.
So there is I think the reason why this question has been asked is there are two things which is called Barker hypothesis and Peterson hypothesis. So one basically suggests because when your fetus is small and which means your fetus is not able, your pancreas is not matured enough, and these baby are more prone for future metabolic complications like diabetes, hypertension, this thing. And in contrary, when you have fetal macrosomia, when you have hyperglycemia, fetal macrosomia, again, this also causes hypertension and this in future generation. So this is called a fetus fuel hypothesis. So when you feed the fetus with more fuel or when you feed the fetus with less fuel, both this thing could cause complications when the fetus grows. So when you maintain adequate euglycemia, this fetus is able to cope better with whatever fuel it has been given. So the fetal programming is very, very important. So when the fetal programming is good, it prevents various long-term complications.
Thank you, doctor.
So if the patient is not willing to take insulin, whether metformin can be used?
Yeah, if the patient is not able to take insulin. Metformin can be used, but it's off-label indication. We can definitely use metformin. And I have even used glibenclamide for many of my patients. You have poor patients coming from, they are not able to monitor, they are not able to do anything. So metformin and glibenclamide might be safer than without being treated, but they are not safer than insulin. In such cases, what I tell patient is, I tell my pharmacist to give a strip of glibenclamide. I tell them, you take this drug, I will not give you any prescription.
Okay.
Because when you give a prescription, it sends a message telling that endocrinologist user, everyone can use it. I said, when I use a particular drug, I know why it has been used. So I have had even patients, one patient was on, she was on glycoside, she was on SGLT2 inhibitor, she was on gliptin, she was on metformin, HbA1c was 8.7. She came to, she was 35-year female and she had irregular periods, and once she went for a routine screening, she was 5 months pregnant.
Oh.
So we stopped the drug, everything, but fortunately she delivered a very healthy child.
Healthy child.
Very healthy child, 35 years, elderly individual, poor glycemic control, varying drugs, which we know, which can cause complications. But of course, these are anecdotal reports. This does not guarantee me using this drug for any of patients.
Thank you, sir. Thank you, sir. You gave us a very good information regarding the management of gestational diabetes. The information was very crispy and informative. Thank you, sir.
Thank you.
Thank you, speaker and chairpersons for this wonderful session. I kindly request Dr. Petukani to hand over a memento to Dr. Kumaravel, sir, please. Thank you, ma'am. We kindly request Dr. Kumaravel to hand over the memento to Dr. Petukani, ma'am, and to Dr. Aarti Kannan, ma'am. Thank you, sir. Thank you, ma'am. We move on to our next session. We kindly call upon Dr. Subbu Rathinam, laparoscopic surgeon, Tuticorin, and Dr. Devan.
Robotic surgeon in Meenakshi Mission Hospital. Now I call upon for your presentation, sir.
Thank you, ma'am. Thank you, the organizers and Arulrhaj sir, for giving me this opportunity. Robotic surgery. Whenever we hear the name robot, slide, keep running. People only think about this. When one patient was offered robotic surgery, he told me, sir, robot la vanda neengale operation pannunga. So they think that it is Yandran robot is going to come and do the delivery like it was seen in the movies. These robots are called humanoid robots. So they are very rare, just because they look like a human. They're very rare. There are only about 3 or 4 humanoid robots in the world, and even they are very rudimentary. They're very slow, nowhere near what is shown in the movies. However, robots are actually very common. You know, I have a robot in my house. Slide. Run it. That's a robo vacuum cleaner. It switches on by itself at night, cleans the house, and works by itself. So, do you know which is the most common robots in the world? Where do you see the most common robots? industrial robots. Almost all our cars are manufactured by robots like these. They are programmed to do certain jobs. They can cut and weld metal. They can do it with high degree of precision and speed. Another set of robots is the industrial robot, the military robots. Run, next. So they can be used to go to areas that are difficult, pick up or defuse a bomb, these things that humans cannot do, and they are being controlled by a human. So basically robots can go to difficult places, can do difficult maneuvers, and they can do it with precision and accuracy. And all the while they are being controlled by a human from a remote center. So these are the same principles that have been incorporated into the surgical robot. Slide. So this is the robot that we have in Meenakshi mission. It is the Da Vinci SI system of robot. We'll have a small walk around video of the robot and then we'll discuss what the advantages are. Slide.
Main components of the robot. This is the main robot which is going to be operated. Has one camera arm and 3D instrument typical numbers 1, 2, 3. The number 3 arm can be located on either side depending on the case that we are going to do. This will attach to the patient's body and instruments will go into these and then they will operate into the patient's body. This is the main console which houses the camera and light source and the computer unit. It has a monitor for the technical staff, the bedside surgeons to see and assist. This is the surgeon's console. So the surgeon sits here, looks into the eyepiece and operates through these joysticks. There are foot pedals for controlling the camera, for controlling the energy devices on the right and left. All these things are adjustable. We can increase the height of the console, the armrest and the distance of the foot pedal. And it can be set according to the surgeon. This is a typical robotic instrument. It goes in through the cannula. It is activated by motors inside the robotic arm. Through these motors, you can see the instrument rotating. These are the cannulas for the robot. They have special grooves which will fit into the clamps. So once the cannulas are placed, the clamps will fit around it. And this black part has to be at the level of the muscle layer so that this part doesn't move in space. No matter how the arm moves, this part will be fixed so that it has to be kept at the level of the muscles. Now I will insert the camera and the tropas and show you how it works. After the human peritoneum is created, we place the ports in the routine laparoscopic fashion. And then we attach the robot to it. So there are special clamps on the arms, robotic arms, which will clamp on this. The grooves will go into the clamp and holds firmly. And no matter how it moves, this point, the black point will always be fixed in space. Now this is the camera. This is a 3D high-definition camera. It goes into the another console like this. Camera. Instrument will go into the instrument arms. The cannulas of this robot are 8 cannulas. They have a reducer where we use the 5 instruments also. So once the instruments are in place, we adjust their position. And once they are ready, I'll show you how it looks on the inside. Now we have docked the robot and attached the instruments. So surgeon sits there. He will look into the eyepiece. There is an interest. So this 3D high definition image. The same image is shown on the TV for the nurses and the bedside assistant surgeon. For the instruments, when the surgeon's head is inside, only then the instrument will become active. You can move the instrument in whichever way you want. You can actually see the amount of degrees of freedom that the instrument has, which show it on the TV.
Now you can see the movement of the instruments, the endo it moves, has a lot of degrees of freedom. And so, last thing, you can also see the external arm movements when they are manipulated in the instruments. So we have to make sure that the external arms don't clash. Both positions have to be raised appropriately. Slide. So we know how the robot is, what it is, how it works and all that, but what is the big fuss? Why do we need the robot now? Now to understand this, we'll go back and take some lessons from the laparoscopic history itself. Next slide. When the laparoscopy first came, the same question would have been asked. Why laparoscopy? It also involved capital costs, buying equipment and instruments and all. But then why not do it by open surgery? Now, after about 25 years, we know the answers to these questions. Next slide. So laparoscopy basically helps wherever you're going to do a small procedure through a big incision. Classic example is cholecystectomy. The small procedure, but the incision is so big. Done by laparoscopy, the patient can actually go to work the next day. But if you put the subcostal incision, he'll be in the hospital for a week and at home for another 2 weeks. The next indication is one of the cases Bennett sir showed. Next slide. Something like an appendicectomy. You can do an appendicectomy with a small incision, but what if the appendix turns out normal? Then you don't know what is wrong. If you had done a laparoscopy, you would have found out that sir did the laparoscopy. That's why you found out that twisted ovarian cyst. Next slide. So basically, laparoscopy reduces the trauma of the axis, improves the exposure. It causes lesser pain and an earlier return to work. Now cut to robotics. Next slide. Does the robot offer any advantage over and above conventional laparoscopy in order to justify this extra cost? And if so, in which cases? So for that, we have to understand, next slide. What are the areas of difficulty in laparoscopy? Now, one thing very obvious is whenever you're operating deep inside a cavity, it becomes difficult. So if you're operating inside the pelvic cavity, the inlet of the pelvis limits the range of movements of the instruments. Keep going. So you can see there, keep going, next slide, next slide. So that side wall, back. That side wall, that gray area becomes difficult to dissect because of the depth and the narrow inlet of the pelvis. And there is a fulcrum effect at the skin level because the trocar is there. Your instrument only rotates about that fulcrum point. And also you lose triangulation. Next slide. There is a loss of triangulation advantage in the depth. What it means is when your instruments meet at 90 degrees, you can manipulate the tissues better. The further you go, the deeper you go, the instruments become more or less parallel. So it becomes difficult to manipulate tissues or sutures at that level. So one of the first uses of robot, please go slow, I'll tell you. One of the first uses of robot was in radical prostatectomy. It is a surgery that is done deep in the pelvis. It requires fine dissection and the urethra has to be sutured after the prostatectomy. Slide. Run the video. Next one. So you have to go around the bladder and the prostate, dissect out the seminal vesicles, cut out the vas, excise the prostate, and then suture it again. All this would have been impossible or difficult with the straight conventional laparoscopic instruments. So there we see the first advantage of the robot, which is the endo wrist. Next slide. Next slide. So this is the tip of the robotic instrument. It has got 7 degrees of freedom. You can rotate in multiple directions, open, close, left, right, and all. This kind of a maneuverability we don't have with the conventional laparoscopic instruments. Next slide. So for a long time, the robot was actually in the urology department. Even in all the institute, it was with the urology department. But with time, CA prostate surgery itself became rare. They were managed by medical management now. But then the lessons that were learned from that could be used to other organs. And the closest organ to the prostate is the rectum. So one very good indication for the robot is an ultra-low anterior resection or an abdominoperineal resection. You can actually do a very good dissection there. You stick to the correct planes. I'll show you a video of an APR that we did, and you can see that. Slide. Okay, this normally in conventional laparoscopy, when you start dissecting into the pelvis, when you enter the pelvis, the plane is parallel to the instrument, so it is easy to dissect. Next slide. But when you go inside, the plane becomes almost perpendicular to your instrument. So dissecting there becomes difficult. We have been doing it, but it is difficult. You will see in the robot video. Next slide. So this is an APR that we did about 3 weeks ago. That is entering the pelvis. You can see the ureter moving there. That is further down, deeper into the pelvis. You can see the vision, the retraction, because even the retracting arm instrument is articulated. You can retract much more than with the normal straight laparoscopic instruments. There about, as you go deeper, you will see the middle rectal pedicle there. There's practically very little blood loss when you're doing this because the vision is so good. The instruments are so maneuverable. You can do everything under control. That's the middle rectal pedicle. That's the anterior dissection. You can see the vagina has been lifted up with the Australia tube there. You can see how well the planes open up with the retraction. We join the anterior and posterior sides. That is at the level of the pelvic floor there. So once this is done, we don't do a combined abdominal and perineal approach. We finish the abdominal part and mature the stoma, everything, and then we put the patient prone for the perineal part. Next slide. So that's after completion of the abdominal part, only these ports are there and the stoma has been matured. Then we put the patient prone and do the perineal part. Next slide. This is a short video that we presented in an international conference. This was a colocolic anastomosis. So we've docked the robot. And then we can do a normal anastomosis just like we do in the open surgery. The same suture material, the same kind of knotting, single layer interrupted anastomosis. So why we did this is we do a lot of end sigmoid colostomies for either trauma or Fournier's gangrene. And when we have to reverse them, that we can do laparoscopically. But when we have to reverse them, they required either a difficult laparoscopic surgery or if for want of time, we would just open and do an open anastomosis. Now, after we got the robot, we've been doing this by robot. We use the same ports that we used for the laparoscopy before, and the patient has no scar. Next slide. The next area of difficulty is the hiatus. Now, again, we can put ports only at the subcostal level, but the hiatus is a much higher level. So again, you lose triangulation, manipulation of tissues become difficult there. Slide. So normally when you want to take a suture, if you want to close the hiatus, it's only perpendicular to the long axis of the instrument. But here you have to close the suture like this. Slide. Close the hiatus like this, which is almost parallel to the instrument, and it becomes difficult. We have been doing it. You have to manipulate the tissue a bit and take bites and do it. But the ease with the robot is at a much higher level. Next slide. Now, this is a truncal vagotomy and gastrojejunostomy. Now, you can see this. That's at the hiatus. And that's the posterior vagus. It was never this easy, even in laparoscopic surgery, because your instrument and the esophagus are almost parallel. You have to hook out the vagus. You have to manipulate, pull the esophagus a little bit and then hook out the vagus. But here you could see that how easy it was because the instrument is articulated at the tip. That's the anterior vagus there. Slide. Next slide. So this is the GJ following it. You can see how the needle can be manipulated. So this bite would have been so difficult in conventional laparoscopy. You can take the needle in any direction you want, inside out, outside in, towards you, on the roof, anywhere. And you can place sutures. And the best thing is you can actually take the bite along the curvature of the needle, which is what we advocate in open surgery. But it becomes difficult in laparoscopy sometimes. But here you can go along the curvature of the needle, which means tissue trauma is very less. Knotting, you can square the knots like you do in open surgery. You don't have to make a slip knot. you can actually see each layer and take bites individually. Next slide. Another thing is that is difficult by laparoscopy is esophagectomy. Again, if you're actually operating straight down from the camera, it's easy. But if you have to go to the neck end or the diaphragm end, again, your instruments become parallel and manipulating the tissues become difficult. I will just show one standard step that we do in esophagectomy. Next slide. So we always hook, ligate, and divide the arch of the azygous vein on the esophagus. In conventional laparoscopy, dissecting the inferior part is easier, it's more standard. But the superior part is always difficult because it's away from you. There's always some tissue sitting there, and clearing that tissue becomes a bit difficult. Next slide. This is the same esophagectomy done with the robot. Because of the articulated instruments, you can go on the superior side, the cranial side of the vein also, and dissect it out very well. You can take the hook behind the arch and make sure that there is no structures there, and then clip it and divide it. Next slide. So big question is, laparoscopic surgeons have always been doing all these procedures all these years, especially Meenakshi missions like the seat of advanced laparoscopic surgery. So what is the big deal? So the main thing is the finesse with which you can do it. Not everybody is a skilled laparoscopic surgeon. And this technology tries to bridges that gap and gives you much better control on what you are doing and much less difficulty. Next slide. Another big area in GI surgery is hepatobiliary surgery. Now, HPB surgery is still done by the open technique in many of the places. That's because it requires a lot of meticulous dissection and a frequent change of instruments direction and all. And laparoscopy with its straight instruments and the fulcrum effect makes it difficult to do it by laparoscopy. Next slide. But now with the dexterity that the robot offers, a lot of HPB surgeons are shifting towards minimal access surgery. Slide. So some of the surgeries that are well suited for this is colorectal cyst, excision, and hepatic osteotomy, which requires a lot of suturing, CAGB, a Whipple, and hepatectomy. Actually, transplant centers now have started doing hepatectomy, donor hepatectomy with the robot. And this has happened in the last 3-4 years. Before that, when I saw my first robotic liver resection, it was very crude. There was a lot of blood loss, and they used a lot of staples. But then within these 3 years, a lot of transplant centers have taken up and they are able to do a donor hepatectomy without any significant blood loss at all. And they do with the same safety as an open surgery, because you know, in a transplant, donor safety is paramount. But they're able to do it now. Next slide. So you can see this picture was famously shared on social media. It was a young daughter who donated part of her liver to her father. The father has end-stage liver disease, so he requires a major operation. That's okay. But this is a normal, healthy paced person. Now we've left her with this big a scar, and the risk of complications of these scars, which you'll see. Next slide.
Apologies to interrupt, doctor. You have 5 minutes.
Okay. So, so much for the patient. Now, what about the surgeon? Somebody said laparoscopy has transferred the pain from the patient to the surgeon. After fundoplication, you'll really realize that all your shoulders are paining. Next slide. Previously, nobody documented all this, but now insurance companies have realized that surgeon fatigue leads to an increased risk of preventable complications in the patient. Next slide. So they've started looking at this aspect. Next slide. In robotic surgery, the surgeon is sitting comfortably and operating. This is the second biggest advantage. Next slide. The third advantage is the 3D high definition vision, like we showed you. Next slide. The fourth advantage is scaling of movements. Can you run the video? Now, the robot allows you to scale movements in these things, 2:1 or a 3:1 ratio. What it means is, if you set it to 3:1, if the surgeon moves his hand by 3 centimeters, the robotic instrument will move only by 1 centimeter. So if you want to suture a fine duct, like say a 5 millimeter bile duct, if you scale the movements and zoom up the image, it looks as if you're suturing a 1.5 centimeter bile duct, which we are all comfortable doing. Now, the level of precision that you can get with this is extraordinary. Next slide. So as with anything, there are always shortcomings with robotic surgery also. We'll discuss cost. I'll come to cost a bit later. Next slide. So it's a two-surgeon job. We need a bedside surgeon and he has to be skilled in laparoscopy. Slide. He needs to do suctioning, clipping and all. Next slide. There is no haptic feedback. So we have to develop a kind of visual feedback. All of us have broken threads while trying to knot in our initial cases. So we have to learn it. Next slide. Port placement is important. So you see this port is actually from the top view, you can't see this port. So if the assistant port is not placed properly, he can't assist you properly. Next slide. Now cost of the instruments. These instruments are all coded for only 10 uses. You can't use it more than that. That means the more instruments you use, the higher the cost will be. So you have to work around all that, try to do some parts of the surgery by the bedside surgeon with the ligature or the clip applicator. Now, if the robot allows you to convert an open surgery to minimal access, like we saw for that donor, that itself will recover the cost. Because in that big Makuchi incision, there is a 30% incidence of incisional hernias. And if the patient has to come back for a second surgery for incisional hernia, it more than doubles what she would have paid for the robot in the first place. Next slide. I will little mention about newer robotic systems. What we have is the Da Vinci SI system. There is also an XI, which is a newer version of Da Vinci. Next slide. This is another latest version of Da Vinci, which is a single port system with snake-like instruments. Next slide. Other companies have also come in like CMR. Next slide. And Medtronic Hugo. Slide. Other specialties, I'm a GI surgeon, other specialties also use it like gynec for radical hysterectomy, surgical oncology, urology, of course. They do prostates. Apart from that, they do pyeloplasties and partial nephrectomies. And some centers have started doing CABG with the robot. If it's only a single disease, they can harvest the internal mammary with the robot and do anastomosis to the LAD. So if properly planned and utilized, robots will change a lot of surgical procedures as we know today. Next slide. Thank you. Thank the organizers for giving me this opportunity. I hope I was able to.
Thank you, sir. Excellent presentation of the modern technique.
Thank you. Thank you.
Now we are planning to enter into robotic surgery in future within short time. We will plan, sir. So even laparoscopy surgery, I did first only in Arulrhaj Hospital. First appendicectomy, I did it here. And then I started doing everything in government hospital also. Thank you, sir, for giving me the opportunity. Now it is the time for us to enter into the other technology, which you have delineated well. And we are all impressed with your surgery. And we will go for Da Vinci system in future, sir. Thank you.
Very nice live demonstrations of robotic surgery. And I have one question. What is the site of ports, port site? How do you choose whether you follow the laparoscopic port, that is the triangle system, have to follow in the robotic surgery, or we have any rules to put a port? Actually,
it varies from system to system. The newer XI system, the SI has been phased out. Now they produce only the XI. There, the ports are just placed in one straight line, 4 ports, and they're all the same size ports. So the camera, you can actually put it into any of the ports. In this, there is a method for doing. For each surgery, you have to place it in the cart, the target anatomy, and your camera has to be in one line. So you have to bring the cart from various positions. For upper abdominal surgeries, it will come from the head level. For rectal surgeries, it will come from the pelvic level. And the ports have to be placed such that there is enough space to manipulate. So normally the camera has to be at least 20 centimeters from the target area, and the side arms, the robotic arms, should be at least 8 to 10 centimeters away from the camera so that they don't clash. Otherwise, you find that the external arms start clashing and they don't give space for the bedside surgeon and all. So in the SI, it varies from case to case, but the general rule is you have to have 8 to 10 centimeters between the instruments and triangulated towards the target.
Again, the triangulated ports it's a target. Okay. How many ports I have to use for a robotic surgery, sir?
There are only 3 robotic arms. So mostly in complex surgeries, we use all 3 robotic arms plus 1 assistant port. So he will do the suctioning and cutting the suture and things like that.
Okay. The assistant by using our manpower.
Bedside surgeon.
Bedside surgeon. Okay. Bedside surgeon only put the incision and put the robotic arms into.
No, I scrub in put the normal virisnil,
Virisnil,
peritoneum,
everything.
put the ports, put all the robotic ports, dock the robot, put the assistant port also, dock the robot also, check everything, and then descrub and go to the console. Yeah. So we are being helped by our residents who keep changing every 3 years. So these things we take care ourselves.
Okay, sir. Thank you, sir. Actually, when a traditional surgery, when lab is overtaken by a traditional surgery, everybody is say about the cost is so high, cost is so high. But nowadays, even the people want circumcision to be done by a laparoscopy.
Yeah, I know. One
That-
patient came and asked hemorrhoidectomy whether it can be done by laparoscopy.
Laparoscopy. Okay. So you clearly delineated each and every cases. What are the cases selection to be for this robotic surgery, and how much this cost will affect the people, and how it will become. I think in future it. Another 10 years and traditional surgery. While I am doing traditional surgery, so MS, PG, traditional surgery is very common. And nowadays the traditional surgery is slightly weaning off with the laparoscopic surgery, and cost is not a matter. So I think the robotic surgery takes another 10 years to come. So how much, what is the effect of cost in public?
Cost does matter now. Like you rightly said, cost does matter now. It will come down with time. So in carefully selected and the counseled patients, we can do it. CABG was a very big surprise because I didn't know that. One of my relatives told me that he underwent a robotic CABG, which is good. If you can avoid the sternotomy, it's definitely helpful. Of course, it is only in selected cases. You can't do it in triple vessel disease and all, but it helps.
Thank you, sir. Once again, I thank you, Chairman and other team, for my suicide pass. Thank you, sir.
Thank you. We kindly request Dr. Subbu Ratinam to hand over the memento to Dr. Srinivasan Ramachandran, sir, please. I kindly request Dr. Srinivasan Ramachandran to hand over the memento to Dr. Subbu Ratinam and to Dr. Devanathan, sir, please. Thank you, sirs. Thank you, ma'am. We shall now move on to the last session of the day, where we have two interesting clinical cases for discussion under the able guidance of Dr. Srinivasan, sir, and Dr. Arulrhaj, sir. The first clinical case is spectrum of pulmonary embolism, which will be presented by our second year DNB postgraduate student, Dr. Manikandan. And this was discussed by Dr. Neelambujan. Over to you, Dr. Manikandan, for your presentation.
Good afternoon to all. Myself, Dr. Manikandan, PG resident. My presentation about spectrum of pulmonary thromboembolism. I am going to discuss about 3 different etiology and presentation of pulmonary thromboembolism. Next slide. This is a small introduction about pulmonary embolism. Pulmonary embolism, when a blood clot or other substance become lodged in the pulmonary artery in the lung and blocks the blood flow to the lung. Pulmonary embolism usually arises from the thrombus that originates in the deep venous system of the lower extremities, proximal more than the distal. However, it rarely also originates in the pelvic, renal, upper extremity veins also, and also in the right heart chambers. Many substances, not only the blood clot, even air during neurosurgery or central venous catheter procedure, or amniotic fluid during active labor, and fat in long bone fractures, and foreign body in torque injections and drug uses, and parasites, egg also migrate towards the pulmonary artery in schistosomiasis, and septic embolus in acute infective endocarditis, and tumor cells also can migrate in renal cell carcinoma. Next. This is my first case, a 29-year-old male woodcutter by occupation presented to our hospital with a history of breathlessness for 10 days. Breathlessness aggravated on lying to the left side associated with the chest pain. History of fever present on and off since 10 days. No history of trauma or recent COVID infection. Non-smoker, non-alcoholic. An examination patient conscious oriented. Tachypnea and tachycardia was present and saturation was 92% at room air. Rest all in respiratory system examination shows breath sounds reduced on right side and stony dullness presence on the right side. In this stage, the diagnosis might be like a right side pleural effusion, lower respiratory tract infection, and acute coronary
Sorry
syndrome.
for the intervention. I request our colleagues to be silent. In another 10 minutes, we will go for lunch. Please.
Next slide. Investigation blood parameter was normal and ECG shows only sinus tachycardia and X-ray shows massive right pleural effusion and HRCT shows right massive pleural effusion with the passive lung collapse of right lung. Next. Course in the hospital, patient planned for pleural tapping around 2,300 ml of star color pleural fluid was aspirated. Then analysis shows exudative pleural effusion. ADA was positive 60. So we started empirical ATT. Then again 1,000 ml of star color pleural fluid was aspirated again. Breathlessness not resolved completely. So planned for echo. Next. Next. Echo shows EF 61% and RV RA dilated. Pulmonary artery also dilated. So mild pulmonary hypertension present. So suggested CT pulmonary angio to rule out pulmonary embolism. Venous Doppler, both lower limb was normal. Then D dimer was 5,500 and homocysteine also elevated in borderline 26 2.0. Rest everything normal. Next. CT pulmonary angiogram advised. It shows a partial thrombus seen in the distal right pulmonary artery extending into the proximal upper lobar branch, causing mild partial luminal narrowing. This is it shows pulmonary embolism. Patient was started on low molecular weight heparin for 5 days, then followed by we started Novak rivaroxaban. His follow-up X-ray shows complete resolution of effusion on right side with the full expansion of lung. Patient was supplemented with vitamin B6 and B12 for hyperhomocysteemia. Patient had improved symptomatically. Then final diagnosis was right massive pleural effusion, tubercular etiology, and right pulmonary artery thromboembolism and hyperhomocysteemia made. Next. This is my second case. Like a 52-year-old obese male came to OPD with exertional breathlessness since 1 week, had left calf muscle pains and swelling. 1 week back, disappeared spontaneously. History of COVID-19 viral infection, mild variety. 1 month back, took home-based treatment. Now in examination, patient conscious oriented, only tachycardia and tachypnea was present. Rest everything was normal. In this stage, diagnosis might be post-COVID-19 sequelae or query acute coronary syndrome, query pulmonary embolism, or lower respiratory tract infection. Next. Then blood parameters was normal. We advised a D dimer, it shows 4,500. Then COVID antigen IgG was positive. Then ECG shows a typical pattern for pulmonary embolism like S1, Q3, T3 with sinus tachycardia. Next. In radio imaging, chest X-ray, only dilated pulmonary artery was there, rest everything normal. Then echo showed EF 63% RA-RV dilated and moderate pulmonary hypertension. Then venous Doppler, both lower limb was normal. Next. Then HRCT chest showed dilated pulmonary artery, trunk right and both left branches also. Sign of pulmonary hypertension, thrombus seen in the both right and left pulmonary artery. It shows a sign of suggestive of acute pulmonary thromboembolism. Next. Then we started manage with the patient low molecular weight heparin and Novak and antibiotics and ICU care. Final diagnosis like acute pulmonary embolism, post-COVID sequelae. Some 52-year-old post-COVID status male came with breathlessness and complete evaluation diagnosed as acute pulmonary embolism. Patient is on Novak and improving. Next. This is my third case. A 50-year-old obese female came to emergency department with complaints of breathlessness since 10 days. It was progressive. Then a known case of hypothyroidism and hypertension on regular treatment since 4 years. History of long travel by bus, 10 days back, more than 8 hours immobilized. On examination, patient conscious oriented and tachypnea present and tachycardia also present. Then saturation was 85% at room air. RS system doesn't show any crackles. And diagnosis might be a lower respiratory tract infection, hypertension, hypothyroidism. Next. Now, patient proceeded with the other investigation. Everything was normal except ECG shows a sinus tachycardia and typical pattern for pulmonary embolism S1, Q3, T3, then poor R wave progression. Next. And chest X-ray also doesn't show any failure changes. And D dimer ordered, it shows 2300. And echo RE-RV dilated, same moderate pulmonary hypertension and mild tricuspid regurgitation present. Next. CT, this is a CT pulmonary angiogram of that patient. It shows partial thrombus seen in the bilateral distal pulmonary arteries extending into their anterior and posterior branches of both sides. Mildly dilated pulmonary trunk measures 32 mm, shows a sign of bilateral pulmonary embolism. Then venous Doppler, both lower limb, no evidence of DVT. Next. Then managed with nasal oxygen and ICU care like low molecular weight heparin started, then NOAC started after 5 days. Patient managed with diuretics, antibiotics, and other antihypertensive. Final diagnosis, acute pulmonary embolism, hypertension, and hypothyroidism, and anemia. Next. This is my small discussion about pulmonary embolism. It is the third most common cause of cardiovascular cause of death and third leading cause of death among the hospitalized patients. Diagnosis is missed about 70% of cases. Pulmonary embolism is the fourth leading cause of pleural effusion also. And despite this prevalence, most cases are not recognized ante-mortem and less than 10% of patients with the fatal emboli have received specific treatment. Clinical diagnosis is difficult because of these two reasons. Symptom depends on the size of the embolus and pre-existing cardiovascular status of the patient, and common symptoms and signs of pulmonary embolism are not specific to this disorder. Next. This is a small signs and symptoms of the pulmonary embolism. And these symptoms, dyspnea and respirospasic chest pain during inspiration. These both are most specific for pulmonary embolism. Then restall, cough, palpitation, wheezing, anginal pain, and signs tachycardia and tachypnea is the most specific signs, and RALs also seen, and loud P2 also seen. These are the signs. Next. This is a diagnostic criteria for pulmonary embolism suggested patient. This is modified Wells criteria, shows a lot scoring. It shows a pulmonary embolism likely if score more than 4. Pulmonary embolism unlikely when score less than or is equal to 4. The next box is like if low probability, if they fulfill all of these criteria, patient might be excluded from the diagnosis. Next. Pulmonary embolism types. In massive pulmonary embolism, hemodynamic compromise will be present, and submassive pulmonary embolism, it's a hemodynamic stable, but it will show the imaging will show the RV dysfunctions like cardiac biomarkers elevated or imaging, echo, or CT pulmonary angiogram. Low risk, no signs of shock or no signs of RV dysfunction. Next. This is a small flow chart about suspected pulmonary embolism in the patient with a shock. If patient presented with a shock, if you are suspecting pulmonary embolism, straight away go and do transthoracic echo. If RV dysfunction shows means just go for CT pulmonary angiogram. If no RV dysfunction, search for the other causes. CT pulmonary angiogram available means you can do CT pulmonary angiogram. If it is not available, it's high probability of the pulmonary embolism, treat like high risk pulmonary embolism. Next. Next, this is show the suspected pulmonary embolism in patient without shock. First, do according to that modified Wells criteria. If it shows low or intermediate probability, do D dimer test. If it is positive, do CT pulmonary angiogram. If it is shows a thrombus, treat the pulmonary embolism. If high probability, no need to do D-dimer, straight away go on to CT pulmonary angiogram. If it is positive, finished one. Next. This is the various managements for pulmonary embolism. And thrombolysis we are using for high-risk patients, like a patient presented with hemodynamic instability. These are all the available thrombolytic agents, and anticoagulation, long-term anticoagulation is necessary. These are all the anticoagulation medications, and surgical options also available. Thank you.
Now we will have the discussion by Dr. Neela Mujan, which we have it as in a video format.
Good afternoon all. I hope you all enjoyed the CME 2022 academic feast. And first of all, my sincere apologies for not being present physically amongst you today. And thank you so much for taking your time to attend this interesting knowledge sharing session. First of all, let me thank Dr. Manikandan for his excellent presentation. He has brought about two scenarios with regard to pulmonary embolism. One is the classical pulmonary embolism. The second thing is the pulmonary embolism, which is associated with COVID pneumonitis. The pulmonary embolism associated with COVID pneumonitis is something new for us because we are very much familiar with the classical pulmonary embolism. We all know that the classical pulmonary embolism is basically associated with certain risk factors to which the patients are predisposed with. Say, for example, somebody with obesity, somebody after a long travel, like which shown in this particular case, can develop a DVT, and following DVT, there is a pulmonary embolism. This is the classical manifestation of pulmonary embolism. The other one, which we are seeing often with regard to the COVID pneumonitis, is something new, where the patient will not have a venous thromboembolism. There is no DVT, but still the patient might develop a pulmonary embolism. Then how do we suspect a pulmonary embolism in such a patient? Say somebody on treatment for COVID pneumonitis develops a more respiratory distress, or when there is an unexplained tachycardia, or when there is a fall in the blood pressure, then probably you have to suspect a pulmonary embolism in such patients who are undergoing treatment for COVID pneumonitis. In such patients, you have to really evaluate for pulmonary thromboembolism. That is the order of the take. The first case and the second case, which Dr. Manikandan has shown that there is underlying COVID pneumonitis in such cases. Basically, in any patient with acute onset of breathlessness, which is presented to emergency department or to the outpatient department, any acute breathlessness, you have to suspect a pulmonary embolism. Especially when there is no much changes in the ECG, or when there is the X-ray which shows almost clear X-ray, but still there is a acute breathlessness, you have to strongly suspect pulmonary embolism and you have to really evaluate. So how do we do that? T-dimer is a very important test with regard to the evaluation of pulmonary embolism when it is suspected. T-dimer basically, it is highly sensitive, but it is got a specificity which is really little low. And basically helps to suspect pulmonary embolism, and it is used as a screening method when you are suspecting pulmonary embolism. What the mind does not know, the eyes don't see. So basically we have to suspect in cases where there is acute onset of breathlessness to diagnose pulmonary embolism. And in clinical practice, what we see is pulmonary embolism is basically underdiagnosed. So we have to be really vigilant in our approach in any patient with acute breathlessness to look for pulmonary embolism, because it is a condition which can be prevented by appropriate measures like adequate anticoagulation. So we have to be really vigilant in our clinical practice to look into such problems. Thank you very much.
I think this is a very important topic because the major proved cause of death in hospitalized patients all over the world, especially the post-operative ward or the ICU, is pulmonary embolus. Indian physicians are denying that pulmonary embolism is uncommon in India and so on for a number of years. And the major procedure that leads to pulmonary embolus is orthopedic surgery, and many Indian orthopedic surgeons didn't use heparin low molecular weight prophylactically till a few years ago. It's because of poor postmortem studies and wrong statistics. And then came papers from Chandigarh, Ramchandra Medical College, postmortem studies from JIPMER, Pondicherry, that it's as high as our incidence of pulmonary embolism is as high as anywhere else in the world. That's the first point. I have personal experience of large number of cases verified postmortem and clinically in cerebral venous thrombosis following postmortem venous thrombosis. And the typical picture is one where they have chest pain, fainting attacks, syncopal attacks, low blood pressure, tachycardia, right ventricular strain in the ECG, goes to toilet and does not return, is dead in the bathroom. This is very common. We have missed quite a number of cases and postmortem has proved it's pulmonary embolus. CSR is always raised, serum fibrinogen is always raised, D-dimer is always raised, and the ECG gives a clue. Low blood pressure, tachycardia, syncopal attacks, and 99% of them have only left leg vein thrombosis. Right leg vein thrombosis is very rare in that context. That's because left leg vein thrombosis is also proximal. 50% of people with leg vein thrombosis will have pelvic vein thrombosis, and 50% of them only will have pulmonary embolus. And the left venous circulation has to travel a long way across the congested abdomen traffic to the right side of the inferior inner cava. That's the reason why left leg vein thrombosis is common. In other words, never ignore a left leg vein thrombosis. You can ignore a right leg vein thrombosis, you may not be wrong. That's all I know. I think it's a major topic, and the final investigation is CT angiogram, which is still available, suspected by low blood pressure, ECG changes, and syncopal attacks.
Enough has been said to create an awareness of the youth on this entity of pulmonary thromboembolism. See, which is easily diagnosable, but it doesn't come to our mind. That is a problem. See, always when there is a breathlessness, we'll have to decide between cardiac and respiratory. When there are RALs, when there is tachycardia, there is cyanosis, we always vote for cardiac. When there are rhonchi and not much of a tachycardia, we vote for respiratory. There the differentiation D-dimer comes. When D-dimer is positive, we vote for cardiac. This is yesterday. Today, you will have to include a vascular component also, pulmonary vascular component. And when there is a, cardiac, we always do an echo, this and that. And here we do a PFT and we try to manage the, bronchospasm. Doesn't settle. Keep this in your mind, especially when D-dimer is positive. When there is tachycardia, when there is breathlessness. Look at the ECG may give a clue. S1, Q3, T3 is a clue. RV prominence will be a clue. X-ray may be normal or may show a right or left pulmonary artery or MPA little prominent. These are all clues. When there is an associated, D-dimer, you can always start the treatment if there are no complications. And the CT pulmonary angio is today, the sheet hanger to make a diagnosis available, you can do that. Another thing that I would like to say is the cough vein thrombus is the commonest cause. Post-operatively, after 6 hours of any pelvic orthopedic surgery, I recommend a prophylactic heparin to be used, a low molecular weight. And when there is no, thrombus in the veins of right or left or anything, that does not exclude pulmonary thromboembolism. Because if you remember the Boyd's textbook of pathology, it says the veins are empty, because the bullet has been fired into the system. It has gone into the pulmonary circulation. Therefore, that is not an excuse. And the sheet anchor is pulmonary angio. But still, when in a breathlessness, when D-dimer is high, you are justified in starting the patient on heparin. Today with the oral, anticoagulants, coolly you can do that. Many other methods of management are also there, but we should not forget an anticoagulant. This is a reminder of our memories in medicine. Thank you. Thank you so much. Thank you, Manikandan. We'll go to the next case. We are already up. Time is up. We are behind 1 hour. Please.
Good afternoon, everyone. Today my presentation is about an approach to a paraplegia based on a case-based approach. Next. Going on to the history, he's a 60-year-old male who was a tailor by occupation, right-handed. It came with a chief complaint of inability to use his both lower limbs since 2 days and not able to void urine since 1 day. Next. An elaborating history, he has inability in use his both lower limbs since 2 days. Initially, it presented as an upper back pain, which was insidious onset, non-radiating, lasting for past 30 days, and aggravated by bending forward, lifting weights, and the intensity also pain up also increased for the past 3 days. He had also a history of difficulty in walking in the form of buckling of knees and tripping of toes since 2 days, which was progressed to the present days. His other history findings suggestive of both the proximal and distal weakness of the lower limbs. Next. He had also a history of numbness and decreased sensation over his both lower limbs, which was
Excuse me, Dr. Chandru. Kindly focus on positive points and positive negative points. Routine system, I think we can withhold, everybody is able to see. Thank you.
He had history of numbness and decreased sensation over his both lower limbs, which was up to his waist level since 1 day, with a decreased sensation in the form of unable to perceive close and not able to differentiate between hot and cold water. Next. And he had history of difficulty in voiding urine, where he was finding difficulty in initiating urine and with the distension of the lower abdomen, but he was able to feel the sensation of the bladder fullness. He had also history of cough with expectoration, which was lasting for 3 months, which was gradual in onset and progressive in nature, and no other history suggestive of any memory or cerebral disturbance. Next. Going to the past history, he had a history of fall from height around 10 years back, which was sustained injury over his left ankle. It doesn't seem to be significant in this case. And he's a known case of diabetic for the past 2 years who's on OHS. And his personal history also doesn't have any significant thing. And family members also no other limb weakness. Next. So after any neurological case, after the history, the thing what you should come into your mind is there is any neurological deficit is there or not, or whether if it is there, then where is the disease, then what should be the disease. Next. So based on our history, the key points what we got is it's a acute onset flaccid paralysis, which was non-traumatic, which plus or minus pyramidal attack involvement, which was symmetrical weakness involving both motor, sensory, and autonomic involvement without any wasting. So based upon this, we are fixing upon the lesion on the spinal cord, probably above the level of T12 and below the level of C8. So next. Going on to the general examination, and general examination finding he has only a tinea cruris. Other than that, rest are normal. His vitals also seems to be normal. There was no external neurocutaneous marker. Next. On 16-week examination, his higher mental function was totally intact. There was no any problem at all. Next. His cranial nerve examination, everything seems to be normal. He has no any cranial nerve deficiency. Next. Coming to the motor system, attitude of the patient, the patient was bedridden and he was catheterized with the attitude of both lower limb externally rotated and extended with both hip and knees and ankle. Nutrition doesn't seems to be any wastings as seen. Going on to the power, his upper limb power was almost 5/5 and lower limb, it was almost 0/5 in from below the hip level. Next. And he had also a truncal weakness. Next. Going on to the reflex, deep temporal reflex, upper limb was normal and lower limb, it seems to be brisk in both knee and ankle reflex, and there was also an ankle clonus. Next. Superficial reflex, Plantar has no response bilaterally. He has cremastic and bulbocavernous absence. But in abdomen reflex, which was present on the upper abdomen, but it was absent on the lower abdomen. So the Beaver sign is positive. Going on to the tone is almost decreased on the lower limb, but was normal on the upper limb. Next. Sensory system, he has total loss of fine touch, crude touch, pain, temperature, joint sense, position sense, was at below the level of umbilicus, which was preserved in upper limb. And his cerebral signs, both Greig and Rombock signs could not be assessed. Next. Other system examination is almost normal. Next. So, except respiratory system, which has he had only normal vesicular burst on, but both sides was a bilateral close crepitation was present. Next. With these findings, so we need to localize the lesion. So we should localize according to the sensory deficit and motor deficit, and with the tone and the change in the reflex, and we should know whether it is an LMN or UMN lesion. Next. So motor level will be fixing at above the L1 and below C8. And sensory level will be about T10. And reflex superficial is about T10 and deep tenderness at L2. So with this, the level of lesion will be at the thoracic spinal cord at T10. Next. So coming to the diagnosis, with the findings, we came into the diagnosis of acute onset bilateral symmetrical flaccid paralysis, probably a non-compressive myelopathy of acute transverse myelitis with pathology at T10 level, and as usual diabetes and tinea cruris. Next. So this might be a differential diagnosis. Probably a GBS might also be given, infective cause and demyelination disorder, vascular, such as AV formation and anterior spinal artery syndrome, and malignance and compressive myelopathy. Next. And general evaluation, everything seems to be normal except this chest X-ray, which shows a bilateral infiltrates. So we taken upon a CT chest. Next. Which shows a bilateral cavitatory lesions, suggestive of an acute pulmonary tuberculosis with a diffuse endobrachial spread. So next we have taken upon evaluation of spine and brain. Brain seems to be normal. Next. But MRI spines, we had some clinching point. The source a total disruption of the D8 vertebra at the T2 image with a peripheral enhancing arterial signal and the intense collection appearing at the level of T7 to T9 vertebra, which might be probably an epidural abscess secondary to an infective cause, but we don't know the cause at all. Next. With this, we can came into the final diagnosis of acute paraplegia, part spine probably, of pulmonary tuberculosis etiology, type 2 diabetes mellitus and tinea cruris. Next. So management comprise of decompression and stabilization and antituberculous therapy, sick diabetic control. Steroids can be considered in acute stages and physiotherapy as supportive care. So going on to the discussion part. So paraplegia usually describes a complete or incomplete paralysis affecting the leg and possibly the trunk muscle, but not the arms. Usually the damage will be at the spinal cord level, at the below T1 or either below the level. So depending upon the onset itself, we can able to differentiate various disease. So acute onset in case of transverse myelitis or anterior spinal artery syndrome, or in case of subacute, like in our case of part spine or spinal epidural abscess. In chronic, usually a familial spastic paralysis or ALS, amyotrophic lateral sclerosis. Next. So based upon etiology, we should classify it as a spastic or a flaccid paraplegia. In spinal cord lesion, we should be able to differentiate whether it is an compressive or non-compressive, after you ruling out an central cause. So usually compressive myelopathy, the predominant feature will be a pain, and the onset will be almost subacute or chronic. But in compressive, usually in non-compressive, usually an acute onset secondary to inflammatory or an infective cause. Next. As I told, these are some clinical clues to differentiate between a compressive and non-compressive myelopathy. As I told, pain and onset. And bladder involvement usually late in compressive myelopathy and maybe early in a non-compressive myelopathy. Next. So in non-compressive myelopathy, you should see the etiology, like whether it is an inflammatory cause or non-inflammatory cause for our treatment purpose. Next. So in compressive myelopathy, it should be very specific whether it should be an extramedullary or intramedullary. One thing, the point which he cleans at dissociative anesthesia, where classically seen in intramedullary lesion. but in extramedullary, pain will be the most prominent feature, probably a radicular pain. Next. So as I told you earlier, it's in extramedullary, extradural pain is a most prominent feature. That's usually a root pain, and intradural, usually a dissociative anesthesia will be there. And as I said earlier, determine the level of lesion based on sensory and motor level. And Beaver sign is one of the things which will differentiate the indicated lesion might be at the T10 level. Next. So take home message from this is, though TB spine is a very rare condition, we have to consider this case in any case of paraparesis with a known etiology. So early intervention will make a recovery possible. ATT should be continuous and spine stabilization has to be done. Thank you.
I think the patient has a paraplegia, which has got features of both compression and myelitis, both together, because the tone is reduced, the sensation is reduced. It's not a spastic paraplegia, as said. But however, body of the spine is also involved. So we must be very careful. Tuberculosis rarely involves body of the spine. We must, however, do a skull X-ray, etc., look for malignancy elsewhere, and make sure that we don't miss some other metastatic problem in this case. Serum calcium, phosphorus, alkaline phosphatase. PET scans have to be done ultimately. Initially, we give antituberous treatment, and if it improves, we can delay our referral investigation. We can only go so far.
As the professor said, tuberculosis usually affects the disc, not the body of the tumor. When the body is damaged, you better consider some malignancy or something, because that is unusual in it. Moreover, a level of lesion, a sensory loss gives you more information than a motor. Again, a lower motor neural lesion gives a more localizing value than an upper motor neuron lesion. Second thing, he presented with a flaccid paralysis, possibly shock. Flaccid paralysis, the brisk reflexes. Okay, thank you.
Thank you, Sundaram, for a nice presentation. So it is one of the classical case of Beaver sign. Already our professor morning itself told about Beaver sign. It is present in this patient. So one or 2 points about the highlighting how to evaluate the weakness. So weakness will be always first you consider it is whether it is a true weakness or false weakness or functional. So first it is true or functional. If you think it is a true weakness, whether it is neurological or non-neurological. So non-neurological cause like rheumatological, orthopedic, any cellulitis will produce weakness. So always, so rule out non-neurological cause. If you think it is neurological cause, define it is a UMN or LMN lesion. So if it is a UMN lesion, so it will be, the tone will be increased, reflex will be exaggerated, and plantar will be extensor. So UMN weakness may be a extrapyramidal or pyramidal or cerebellar. So extrapyramidal weakness, it has slowness, involuntary movement, cogwheel rigidity. If it is a pyramidal weakness, the tone will be increases and reflexes will be exaggerated and plantar will be exaggerated. Cerebellar, we can get the cerebellar incoordination, dysarthria. These are the features of the UMN weakness. If it is LMN weakness, you fix it in the anterior cell disorder. So it may be present with fasciculation. If there is a sensory root involvement, like diabetic neuropathy, we can give like predominantly a hyposthesia, dysesthesia, paresthesia, like that presentation. If it is motor and motor roots are predominantly involved, GBS condition, predominantly a proximal weakness, reflex will be reduced and tone will be reduced. And if it is neuromuscular, next is neuromuscular dysfunction, it produces fatigability and diurnal variation. Lastly, muscle disorder, mostly it presented with the proximal weakness, pseudohypertrophy, and reflex will be maintained. So you have to fix it in any of the one of the lesions. So here he is fixing it with the spinal cord. The myelopathy means pyramidal tract involvement. It produces paraparesis. So this is the one thing I have to tell about how to evaluate weakness. Thank you.
Thank you, Dr. Kannan. We request Dr. K. Sir to hand over the mementos to your co-guide, Dr. Arulrhaj Sir and Dr. Kannan Sir, and to both the presenters, Dr. Manigandan and Dr. Chandrakumar, please. Thank you, sirs. We have now come to the end of our scientific sessions. Please spare 2 more minutes for a short valedictory function. We request our Tuticorin IMA branch president, Dr. Chandrasekhar sir, to say a few words and felicitate us, please.
Good afternoon to everyone. And the pre-lunch session, this was a very wonderful and very excellent CME for all the Tuticorin doctors, especially the robotic surgeries and gestational diabetes. All very interesting clinical presentations. And I congratulate Dr. Professor Arulrhaj sir and his SIH team for this wonderful annual CME program. You all know that he has been conducting all the CME programs for the past nearly 15 years, more than 15 years. From the days of Dr. Misra and Dr. Srinivasan sir. Sir, I welcome you, sir. After a long time, we are seeing you. It's very nice to have him with us. We had wonderful lectures from him previously in our Tuticorin IMA, and our Arulrhaj sir was instrumental in conducting all the CMEs in Thoothukudi. We are happy to travel with you, sir. In Thoothukudi, you are having wonderful CMEs. And to say a few words about our professor, he is balancing between good community service to the patients, continuing medical educations. Even during COVID times, he conducted these Zoom meetings. And I used to watch when I was in USA. I used to follow him in all the continuing medical education programs. And this is the first hybrid meeting he is conducting. And he has his service to community by conducting awareness camps and this walkathon to create awareness about prevention of diabetes, hypertension, cardiac problems, etc. And he is balancing between academics. Also, he is running DNB, Family Medicine and School of Nursing, etc. Above all, he is leading all the physicians of our India as president of API. I'm happy to see Dr. Neelamujam, Archana, Arti, Kannan are supporting him in his conducting all the CMEs. And I thank all the SAH team also. On behalf of IMA, Thoothukudi, we thank you, sir, for the wonderful enlightening CMEs throughout the year. And today is the culmination, which was an excellent presentation. And we wish you good health and wish you to continue your noble service to the medical fraternity, sir. Thank you very much, sir. Thank you.
Thank you. Thank you very much, sir, for your blessings. Thank you very much. We request Dr. Narendra Jana, sir, to hand over a memento to the IMA president, sir, please. Thank you, sir. Next, as a token of gratitude, I would like to appreciate my entire hospital's CME team for their tireless efforts for the past 10 days in making this CME a success today. I request our chairman to hand over a few appreciation awards to our team, please. First, I would like to call the mistress of ceremony with me, Ms. Ramya, please, to receive her memento. Next, I would call upon my dear friend and supporter, Judy. Next, our manager, Mr. Bosco. Our marketing team, Mr. Ivan, Mr. Vignesh will follow. IT team, Ms. Vaishnavi. She will. Photo. Vignesh, va. Vaishu, va. Vaishu will also receive Ms. Delcia's award also. Delcia. Next, we have the admin team, Mr. Arjun. One of our pillars, Mr. Raja. Next pillar, principal of our nursing college, Mrs. Elizabeth. Okay. HR, Mr. Milan. Sophia. Parameshwari. And all the cutie students, Brinda and Sophia, Arul Devi. Brinda. Ivan, நீ ரவிக்கு மட்டும் வாங்க. ரவி தான் மட்டும் நீ வாங்க. Yeah. Thank you very much, sir. We thank all the delegates, speakers and chairpersons without whom the CME would not have been a success. Let's all meet in March 2023 for the next ACME. Kindly join us for the high appetizing lunch available on the hall outside and also on the 4th floor, please. Thank you very much. Stay safe. Have a happy Sunday. We thank also all the audience who had joined us for the hybrid meeting virtually too. Thank you very much.